Okay. Good morning, colleagues. Good morning. I didn't hear you. Good morning. I know we are few, but we can answer. Good morning. There you are. Would I request us that we just move 1 or 2 seats ahead? Most of the black seats are not even occupied today, so if you can move, just don't stay at the back. Kindly just take 1 or 2 steps ahead so that we can be a sizable group of people. You can't hear me? Now you can hear me. All right, thank you for the heads up. So colleagues, kindly just make 1 or 2 steps ahead. Thank you. Okay. We need to fill these seats in front of you. You are the VIPs today. So don't sit right at the back. I see you guys. I'm waiting for you to just move a few steps ahead. Kindly. Yes, thank you. All right. 1 or 2 rows will do. Okay. So that those who come late can join us on those seats at the back. So welcome to day 2. Day 2, we now have gathered momentum and we enter into serious business. Yesterday, we were doing the high-level bit of the conference, and then we had 2 very interesting sessions. One was looking at the background and was looking at the progressive review of the NCD prevention and control narrative in Africa, and we had Dr. Kofi and Dr. Jean take us through mostly around the regional trends of NCD and the investment case for the same. And then Professor Makani took us through resource mobilization, partnerships, and accountability for NCD action. And we had ministers of health take us through their thoughts around strengthening global and regional partnerships, around the African health sovereignty, and around exploring public-private partnerships, and we usually add the people in the 4th P, and the blended financing models to halt and reverse the burden of NCDs. And then finally, we had Dr. Sako Binta, my colleague, looking at country progress and priorities in NCDs control and management. So today we are looking, yesterday we looked at the what, and we were in agreement that yes, there is a problem. We measured the size of the problem, and we looked at some of the solutions that we have. And today we'll be looking more of the how, and also asking the question of what now? Now that we realize we have this challenge, and we realize we are struggling in some places to implement some interventions, how do we scale these interventions? How do we institutionalize them? How do we make them part and parcel of the UHC response, or the day-to-day management, or the day-to-day health delivery in our countries? So I will be your moderator today, and I'll be stepping in also for Dr. Jones on the second session. And to start us off, and so that we can catch up with time today, we want to make sure you have lunch at the right place and at the right time. I will be calling Dr. Joseph Moga, my colleague. Dr. Joseph Moga from WHO, please come over. You will be moderating the next session, that is session 1. And the first session, we are looking at the overview of the PEN Plus and progress in the WHO African region. And of course, you will be having 2 eminent colleagues to speak about this progress. And then after 30 to 45 minutes, I will be taking over. So Dr. Joseph, the floor is yours. Thank you.
Habari ya subuhi. Hey, there's nobody who understands. I thought Kiswahili was born in Tanzania, grew in Kenya, got sick in one of the East African countries. Yeah. So welcome again. I think we are set for a very interesting day. The first session, I think we should start right away. It's an overview on PEN Plus and progress in the WHO African region. We shall have 3 very interesting presentations. And delighted to invite our three presenters for this morning. Dr. Kofi Nyarko, the NCD team lead Afro. Can you please come and take your seat? Dr. Neil Gupta, NCDI Poverty Network, and Dr. Mary Mayiga. You are welcome to take your seats. I don't see Dr. Kofi. Dr. Kofi, are you? So as we wait for Dr. Kofi to take his seat, this morning's session basically is we are going to look at the PEN Plus. When it started, how far we have come, what are some of the lessons learned along the way, and how we get forward from here. Welcome, Dr. Kofi. So this session actually sets the stage for the following technical sessions today. So at the end of the session, we hope that participants will have a stronger understanding of what PEN Plus is, a clearer picture of where we are as the region, and some of the lessons learned along the way, and how we can accelerate implementation from here. So it actually sets the stage. We take a pause and ask a question, how far we have come. Today is actually about 4 years ago since the member states endorsed the strategy. So our first presenter will be Dr. Kofi Nyarko. Dr. Kofi Nyarko leads the NCD team at Afro. We can have no better person to present the overview on the strategy than Kofi Nyarko, because he's really at the forefront of coordinating the implementation of member states, engagement of partners, and so he's leading from the front. So Dr. Kofi Nyarko, we are most welcome to give us and really see where we are as far as PEN Plus is concerned. Let's give a round of applause to Dr. Kofi.
Thank you very much, Dr. Moga, and good morning to everyone. I'm presenting on the overview of PEN Plus, the progress, where we started and where we are. Slides, please. I'll present some few slides. Next slide. Okay, so I'm sure from yesterday's presentation, we all know something about PEN Plus, but for WHO Africa region in 2022, there was a regional strategy on PEN Plus to address severe NCDs using at least 3 diseases, type 1 diabetes, rheumatic heart disease, sickle cell as entry points. And these were endorsed by all the 47 member states, the ministries of health and government, to ensure that this is done in our region. And why did we have this PEN Plus strategy? We had a WHO-PEN, which looks at NCDs at the primary care. WHO-PEN is package of essential NCD interventions, which looks at basic NCDs, hypertension, diabetes, usually type 2, which is easy to manage. It looks at basic, even screening for cervical cancer, breast cancer, other NCDs. So when the pool pen became active and increased coverage, we realized that if you look at the health system in Africa, it is in 3 tiers. At the primary healthcare level, where we have mainly health centers or health posts, people go there, and when there is, for example, severe hypertension, the people there, mainly health officers, are not able to manage these cases. If you have type 1 diabetes, you need insulin. You need to titrate, and these health officers are not able to do. And also in Africa, we have what we call general, it's not a specialty. When you finish medical school, you have an MBCHB or MBBS, and these people manage general conditions, but not specialized care. So we realized there was an access to care in terms of those specialized NCDs. So we needed to have this PEN Plus strategy to address the access gap. So this was endorsed 3 years ago, and as we indicated yesterday, we had funds from Hemsley to start piloting and see how it works in these 20 countries. So this model complements the WHOPEN, as I said, and the guiding principle is a whole of government, multi-sectorial, whole of society approach, so that it's not done in parallel, but as an integrated and complementary. So in summary, these are the 4 main objectives of the PEN Plus strategy: to strengthen the availability of and access to quality care for severe NCDs, so that when you are in the district level, you get into contact with our health facility, you will not be asked to go to your national capital where you don't have money to go, but you have the care needed in terms of quality care. We also look at capacity of the workforce, because this was some of the major reasons why we had healthcare workers mid-level, but they were not able to do the management. And also availability of essential medicines. In Africa, I'm sure we are all aware, most of the time we use insulin as an indicator. You go to the facility and there's no insulin. You go to the facility, there's no insulin. But not only insulin, there are other essential NCD medicines. So we ensure that this is there. And we need data for decision making, support monitoring and evaluation, and research on PEN Plus interventions. So this is what the PEN Plus is about, and we are looking at by 2030, what do we achieve? And that by 2030, 75% of member states, we have 47 member states, will have standardized protocol-based management for severe NCDs, integrated in the health policies and strategies, and that by 2030, 70% of member states will have at least protocol-based management for severe NCDs in national plans. The national plans will have these integrated, establish national training programs. We have training curriculum that will help us train according to the severe NCDs model, essential medicines, and lastly, by 2030, all member states will have a system for collecting mortality data. Perhaps you are aware, in Africa, as we presented yesterday, most of our mortalities are due to NCD, but we don't have very good systems. Our mortality surveillance system is weak, and we hope that this PEN Plus approach will help us improve this mortality surveillance, which we are doing as part of the work, and I will show where we are. Next slide. Country progress. WHO Afro is supporting 20 countries, which you can see. As was presented yesterday by the Rwandan ministry, they have achieved 100% coverage because they started even before the PEN Plus strategy was adopted by member states. Malawi has about 55% coverage. The rest of the countries that we are working with now, most of them are in phase 4, where patients are being enrolled. Compared to previously when we met in Nigeria last year, the ICPPA, where most countries were training and awaiting enrollment of patients. So this is the level where we are, with just about 1 country at phase 2. So we have it up to phase 5. And national coverage means you have more than 60% of your facilities implementing PEN+. Malawi is 55, so I hope that in the next 3 months, they will move to the last phase to have at least 60%. Since I can see the WR of Malawi here, I hope in 3 months they will get there. Next slide. So this is to show some of the things we have done. All our 20 countries, as I said, we've progressed up to phase 2. National stakeholder workshops have been done. National operational plans, now all the countries, if they've not completed, they are almost finalizing their operational plans to move forward. And you can see some of the countries with the operational plan. We have a sickle cell intervention package, and sorry for the. We have guidelines on rheumatic heart disease, and we've also developed a PEN+ global monitoring framework will help us with our monitoring of indicators, and as I indicated, mortality surveillance. So these are some of the technical products we've developed, and we still have more that I'm not showing here. This is just a summary slide. Next slide. In the area of service delivery, last year we were around 60 districts, but now it's been doubled. In terms of enrollment of patients receiving ongoing care, since we started those countries and districts where we are implementing, in terms of the indicators for severe NCDs, we have done over 100,000. Healthcare workers, 17,000 have been trained. They continue to be trained. The last country that did training was Congo. I think 3 weeks ago, there was training in Congo, Republic of Congo. Then another good thing that we have done, because people still continue to ask us about PEN+, how can we be trained? So we have developed an online course on PEN+ at WHO Academy, and we have several modules. Now the first phase is done, which I will show with our QR code that you can scan as we go along for you to have a feel of how the course is. There are other modules that are under development, and patient service data integrated into the DHIS2, and that has been done in Ghana and Uganda. And in the next phase, we are going to add a few more countries to it. And what we have now, other countries can use and contextualize using their country DHIS system. Next slide. One of the good things that we have done is advocacy in terms of communication. ICPPA is one of them. We have various advocacy reports, which we had some in our booth. I think most of them we have to fill the booth again. We have so many documents on social media. We are showing the world what PEN+ is doing. And one of the success stories for us is Eswatini. Once they saw what PEN+ is doing, they moved themselves as a country, and they've started the implementation, and they are the second phase of implementation with their own resources. And because of this good initiative, we are going to support them with other partners to ensure that at least within a year, Eswatini will show the way and move from within a year from phase 1 to phase 5. And I know the WR is here and they'll be able to deliver, because now we are going to make sure that we move in the accelerated phase of PEN+ in our region. So we have a lot of communication products and advocacy products that is helping us increase awareness on PEN+ and its outcomes in our region. Next slide. So this is showing the implementation of PEN+ course. We have what we call WHO Academy. It's part of the WHO system, which seeks to support training in capacity building, and most of our courses are online, and others are also in person in terms of hybrid. So this course has been developed. The first part is on the introduction of PEN Plus. What is PEN Plus? What is the steps if you want to do it from the planning phase to the monitoring to implementation, and how to ensure that you are developing and being able to monitor your progress. So you can test the QR code to see how it looks, and I think at the end there will be a place that if you need to give us comments on how to improve the course, is welcome. So this is one of the good things that is going to help us build capacity in our region. So with the PEN Plus, in summary, that is where we are, and to ensure that countries will be able to move with us to implement. And it's our hope that in the next 12 months, almost the whole of the region will be willing to implement PEN Plus, and with the little resources we have, and with the support of our partners, we will be able to guide them to move forward with PEN Plus implementation in our region. Yes. So going forward, there are 6 things that we want to do as a region at a minimum. We are at 20 now. We want to move to 30 countries by adding 10 additional countries. Tomorrow there will be a program to indicate our proposed countries, but countries that are not part. Once you indicate that you are willing, like what Eswatini did, you'll be able to bring you and add you to the 10 additional countries. So we want to sustain and expand financing, mobilize blended financial models that combine domestic budgets and catalytic donor investment. So this is one of our priorities in the region. Build human capital, train mid-level workforce, roll out WHO Academy digital training modules. Innovate and integrate. As I said yesterday, integration is the key. We need to integrate what we do and to support local innovation, including low-cost diagnostic, telemedicine, regional medicine production, including e-learning and digital health, whatever innovation we can do to improve our outcomes. Reinforce data and impact, strengthen surveillance and data for evidence-based decision. And lastly, and most importantly, we think advocacy, elevate political visibility like what we are doing today, engage high-level leadership, mobilize strategic partners to sustain the momentum, and prioritize severe NCD care. The 2030 SDG target is to reduce mortality due to NCD by 1/3. And we think it's the severe NCDs that leads to mortality. So once you deal with PEN Plus, you will reduce mortality and be able to achieve the 2030 SDG targets. So this is our priority action going forward as a region, and we hope that we all come together and move towards this goal. Thank you very much for your attention.
Thank you very much, Dr. Kofi. That was wonderful. So Dr. Kofi has shown us the vision that PEN Plus was, the vision set by the member states on PEN Plus, and also how far we have come in the last 4 years. It's great that 20 countries are on board and 10 more are being earmarked to be on board. That is great. I think we look towards much more engagement of countries. Allow me also to recognize the presence of all the delegates around, the permanent secretaries, our WRs who are in, our partners, delegates from Ministry of Health, UN agencies. You are most welcome and feel at home. So we are clear with the vision and the targets that were set by PEN Plus. The next thing is actually now translating that vision into action at the country level. So our next presentation is going to look at experience and achievements in supporting 10 Plus implementation and scale up at the country level. We are glad to have Dr. Neil around to give us this presentation. Dr. Neil works with the NCDI Poverty Network. NCDI is one of the very important partners that has really taken the implementation of PEN Plus to another level. So we really appreciate the efforts of NCDI Poverty Network. So Dr. Neil is actually, he's a senior director of policy for the NCDI Poverty Network, and he leads efforts to support national NCDI poverty commissions in many of the countries members around. And also, he is part of the network steering committee. So, Dr. Neil, you are most welcome, and we look forward to your presentation. Thank you.
Good morning, everybody. I hope you can hear me well. I'm having some difficulty hearing, so one recommendation, if you're old like me, is to use the headsets also. You can put them on English, so you can hear actually much clearer. I think it's helpful. Now, if you're feeling cold, I don't have any advice for you, or blankets. You can just, bundle up. That's how we'll spend the rest of the day, frozen here together. It's so nice to see so many friends and colleagues in the room. Many of us have been working together for the past 10 years or so. So it's a pleasure to be with you all. And as we know, most of the learning and most of the knowledge exchange is not here from the podium, but it's in the corridors, it's the discussions, it's the side meetings, and looking forward to meeting you all. So if my job today is to tell you a bit about our role at the NCDI Poverty Network, why we have this unusual name of NCDI Poverty, what that means, and how we work together with WHO to make PEN Plus a reality towards the regional strategy, milestones, and targets. So next slide, please. I want to start the story. You can move to the next slide. Thank you. And even the next slide. I'll come back to this in a moment. Thank you. I want to start the story for the NCDI Poverty Network back in 2013 when we convened a meeting of policymakers from around Africa, South Asia, South America, together in 2013. So this was 13 years ago. Right at the time of the launch of the Global Action Plan from the WHO. The launch of the Global Action Plan was a momentous occasion and really brought the global community together around NCDs. But there was a lingering question from many policymakers around Africa regarding many of the NCD conditions that they were seeing in their own context that perhaps were not included in that Global Action Plan. Perhaps they were mentioned in the earlier Brazzaville Declaration from WHO Afro, but not quite included in that 4x4 matrix that was presented through the 2013 Global Action Plan. Next slide, please. So all of us know the 4x4 matrix quite well. It's 4 common NCDs and 4 shared risk factors, which has been updated and modified as time has gone on to be more inclusive of additional risk factors such as air pollution. Next slide, please. And I think we're all very familiar with that 4x4 matrix that's here on the right side of the slide. But in that 2013 meeting, there was discussion on a much longer and perhaps more relevant list of conditions that were affecting the populations of the countries where the representatives were coming from. So these were conditions such as rheumatic and congenital heart diseases, type 1 diabetes, sickle cell and other hemoglobinopathies like thalassemias, epilepsy, injuries, mental health conditions, the list went on. Some of these conditions, as you see, might be individually less common, but the risk factors were often related to socioeconomic context or for populations living in extreme poverty. And what we also learned was that many of these conditions were actually affecting younger populations. Next slide, please. So after following that meeting, we launched a Lancet Commission, the Lancet Commission for Reframing NCDs and Injuries for the Poorest Billion. Next slide, please. And that gave us an opportunity at the network to conduct several analyses actually looking at this hypothesis. So this slide shows one of the analyses from the Lancet Commission, which displays the DALYs, disability-adjusted life years, due to the 4x4 conditions in the population of the poorest billion globally. And you can see, even though this is quite small, but you can make out that most of those DALYs were concentrated in older populations, 50s, 60s, even 70s. However, if you can move to the next slide, when we looked at conditions that were perhaps not included in the 4x4 matrix, you can see that there was a much more diverse set of conditions, as well as conditions that were affecting much younger populations, even into childhood and infancy. Next slide, please. Many of those conditions, as we know, may not be as common as hypertension or type 2 diabetes, but perhaps they're more individually severe. So conditions such as sickle cell disease or congenital heart diseases, although they're less common, they result in many, many years of life lost due to the early severity, early morbidity, early mortality due to those conditions. Next slide, please. So in the Lancet Commission, we had an opportunity to look at all of the health system interventions that are related to NCDs. And if you can go to the next slide, what we found is that many of those interventions, which actually have the greatest impact for the populations living in the poorest billion globally, occur at district hospital level. So I'm trying to give you background of where and how we came to Penn Plus as a key integrated delivery model for NCDs. Next slide, please. So the conclusions from the Lancet Commission were that there's a diverse set of NCDs and injuries in addition to the Global Action Plan and 4x4 model from the WHO at the time, that those conditions were often early in life and affected populations living in poverty, and that NCDs and injuries were perhaps the largest gap in achieving UHC, or even now what we're calling primary health care. Next slide, please. So following the Lancet Commission that was doing a global analysis, we engaged stakeholders from many of the same countries where you are all representing today. Next slide. And we supported ministries of health and implementing partners to establish national commissions where they can conduct a similar analysis specifically for their own populations in the context of their own countries. This is just a few pictures. Many of you are actually in these pictures. I could actually name several of you who are hidden in those slides. But now we're now working with 29 countries in these national NCDI poverty commissions. And next slide, please. Each of these commissions produced a series of reports. These are all available on our website, and I'm going to give you a QR code in just a moment, so have your phones ready. Next slide, please. But these commissions went through a priority-setting process and identified which NCD and injury type conditions were impacting their own populations. And they found 15 NCDs and injuries, many of those that I mentioned earlier, that were common in most of these countries. And then they actually went through a costing analysis to look at what type of budget it may require to address those severe and childhood NCDs in addition to the traditional 4x4 conditions in the context of their own countries. Next slide, please. So that brings us to the NCDI Poverty Network, which was a convening or coming together of these 29 NCDI poverty commissions that I mentioned. And we have a four-phase theory of change, which we work with each of the commissions to complete the situational analysis, to co-design integrated care delivery models, such as Pen Plus, to begin initial implementation of those clinical delivery models, and finally, national scale-up, just as Dr. Kofi was mentioning around Pen Plus initiation and scale-up. Next slide, please. The NCDI Poverty Network is based with two co-secretariats, one at Harvard Medical School and Mass General Brigham Hospital in Boston, where our center is, Center for Integration Science. And the second is in Maputo, Mozambique, at the Universidade Eduardo Mondlane. And we have many colleagues here from each of those secretariats. Next slide, please. So from the center, as a WHO collaborating center, we have been asked to support WHO Afro with achieving the targets of the regional strategy for Pen Plus. Next slide. And the way we do that is by supporting financially, technically, the establishment of training centers for Pen Plus, so initial clinics, training centers in now 14 countries, many of those here in sub-Saharan Africa. Next slide, please. And I'm happy to say that we have now reached over 24 training centers, or established 24 training centers, done a rigorous training for over 500 frontline providers or non-specialist mid-level providing clinicians. And now, for the first time at this conference, announcing that we've reached now over 25,000 patients enrolled in care. Next slide, please. Dr. Emily Rowe, who many of you know, will be speaking on tomorrow and providing you with our first look at clinical outcomes, excuse me, from those patients enrolled in care, to really see what type of impact it's making in each of those individual lives for those 25,000 individuals, and we hope to reach many, many more. Next slide, please. Now this is the time to pull out your phone. I hope you can take a snapshot of this QR code. It will give you something to do while I finish the rest of my slides and to look at, which is a complete resource library of all of the materials that have been utilized and developed to develop a set of programmatic standards for Pen Plus. So if you're still curious, what exactly is Pen Plus? What are the components? What are the details? They're all available in this file, and they're available in English,
in French, and in Portuguese. Maybe I should pose. I was going to pose with the QR code so I can, be together with it, but I'll spare you that. I hope everybody's had a chance for the QR code. We'll go to the next slide. So what do we do at the Secretariat? And I'll be just brief. We convene Pen Plus implementers, many of whom are in the room, with the Pen Plus technical team, many of whom are also in the room and responsible for many of the materials and achievements that I'm presenting today. We host monthly technical sessions, study tours. We have a Francophone community of practice for many of the early implementing countries in Francophone Africa. And we'll continue to do this over time and hope to bring in more of you all into those learning experiences and community of practice. Next slide. Finally, and I'll wrap up with these slides. For those countries who have implemented PEN Plus, one of our major efforts from the Secretariat, as Dr. Kofi was mentioning, is to support the production of national operational plans. And national operational plans are an opportunity to learn from the initial implementation experience and to provide a roadmap for scale up, to engage ministries of health as truly leading and coordinating these efforts, to demonstrate how PEN Plus is integrated within existing policies and health systems, to project how much resource is needed, how much budget is needed to scale up, and then finally to bring in those partnerships that we've all been discussing today. Next slide. Speaking of partnerships, if we're truly going to achieve a high level of coverage and scale up of PEN Plus, it will take partnerships. I think that's clear for everybody in the room. We have more and more institutions and organizations that are becoming involved in this PEN Plus movement. Happy to show these here, but this is just a subset of the organizations that are on board and supporting in some way. Next slide, please. Also, I'm very happy to say, as we demonstrated yesterday with our high-level representation, which we're honored to present for, at the UN high-level meeting for NCDs and mental health last year, 8 ministers of health spoke on PEN Plus and the importance of inclusion of PEN Plus in the NCD agenda for the coming years. And in the center here is His Excellency Minister of Health from Mozambique, who was speaking here on the podium yesterday, but has been a true champion for PEN Plus in the region. Next slide. My last slide here, just showing again a Lancet editorial that was produced just several months ago, describing PEN Plus as a first step to better care. I think we've taken some first steps already. You can see 2 years ago, sitting in the same auditorium, last year, the wonderful group led by Dr. Kalu and Dr. Kofi in Abuja. I think we're taking another step to better care here. And I hope we can take many, many more steps together towards those funding targets, towards those technical targets, towards those regional milestones that Dr. Kofi was describing earlier. So thank you very much. I'll end here and looking forward to more discussions. Thank you.
Thank you very much, Dr. Neil, for that wonderful presentation. We welcome the arrival of additional excellencies and WRs. You are most welcome. Basically, we are in the session 1 of today 2, which is looking at the PEN Plus progress and the status in the region. So we have had so far 2 presentations. One from Dr. Kofi, which is about basically setting the vision. What was PEN Plus meant to achieve, and how far we have come along that journey in the last 4 years. And Dr. Neil has given us what actually translating the vision into action looks like. The commissions, the operational planning. I think that's tremendous work from HDI Poverty Network. Dr. Neil is particularly very passionate about operational planning, and I think many of you in the room can attest the fact that from Kenya, Ethiopia, Zambia, Malawi, Zimbabwe, who have launched their plans, Dr. Neil has been very instrumental in supporting the countries in the development of the plans and implementing them above all. So now we are going to the last session, which is actually looking at what success looks like. And we've traveled all around the world to come to Tanzania to have an idea of what success looks like. And among us here is Dr. Mary Mayiga. She will make a presentation. Dr. Mary Mayiga is a principal research officer and a director of research, information and regulatory affairs at the National Institute of Medical Research. Basically, she has been a crucial member in walking the journey of Pen Plus from policy to research to implementation in Tanzania. So there is no better person who can give us how success looks like using the case of Tanzania than Mary Maiga. Dr. Mary Maiga, welcome. Let's welcome Dr. Mary Maiga. Thank you.
Good morning, ladies and gentlemen, Your Excellencies. I first would like to thank the organizers and the Tanzanian team for giving me this opportunity to tell the Pen Plus story from the Tanzanian perspective, but I also thank the NCDI Poverty Network and WHO for working with us throughout this journey and the amazing support that we get from the Ministry of Health Tanzania. Can I have the slides, please? Okay. Thank you, finally. So, as I said, I'm going to give the Pen Plus implementation perspectives from the Tanzanian experience. And as I have been introduced, my name is Dr. Mary Maige. I come from the National Institute for Medical Research, which is the implementing partner coordinating Pen Plus implementation in the country. Next slide, please. So in my next slide, I'm just giving you a bit of data from Tanzania so that to set the stage for what I'm going to talk about in the next slide. So we have currently a total population of about 70 million. This is a 2026 estimate, and a population growth rate of 2.7% annually. And majority of our population live in rural areas, so about 64 and 36% in urban areas. And majority of our population is younger individuals below the age of 15 years. And our life expectancy currently at birth is 68.6 years. Next slide, please. We were told yesterday, I don't want to dwell much on this slide, but we were told currently the burden of NCD is about 39% as the main cause of death. But I want to stress the fact that we have an estimated 11,000 births with children born with sickle cell disease annually. And we have quite a high proportion of sickle cell trait carriers. I think it was estimated around 20% of the population, and we have an estimated around 7,000 children under 19 years are living with type 1 diabetes in Tanzania. So the numbers are really there, and we have these patients, so we have to know that Pen Plus services are actually needed. We have these patients that require these services as presented by Neil previously. Next slide, please. So I want to reiterate that Pen Plus implementation really hinges on three key things. There's more than that, but I wanted to stress on these three pillars. The first one is service delivery. We need to have dedicated services to ensure that the patients that require these services actually get them to the minimum standards that are required. And the next one is, it's really important to make sure that the workforce, the clinicians and the people that are working at these clinics are well trained and are able to provide these services, because as we have been informed, these are patients that have severe conditions, and we have to make sure that the people that are delivering the services at this level are actually well trained and have the skills to deliver. So there's being trained and there's having the skills, so we have to make sure that they are imparted with the skills to provide this level of care. And more importantly is to have the data systems to integrate the NCD clinical indicators to set, I think this is the main gap that we have, to set the accountability framework to make sure that we can monitor our inputs, but we can also monitor the outcomes of patients and make sure that we can also track our progress in real time. Next slide, please. So in my next slides, I'm going to talk now what as a country, what have we been able to do and what have we been able to achieve and where we want to go. And one thing that I want to stress also, it's important to have multidisciplinary staff at the clinics, because we've heard yesterday, I think we were shown a video at the opening session. It's not just patients, these are real people that have real circumstances. So we need to have a multidisciplinary team that can address all the challenges and can provide the opportunity that these patients require in able to live not only a normal life, but to thrive and achieve their dreams. Because we've heard from the yesterday's video that patient with sickle cell, she wants to be an orthopedic surgeon. So we really need to have the services that can make sure that these patients that have these real dreams are able to achieve their dreams just like any other children that are not having such conditions that they're living with. And then in Tanzania, we realized that it's important to have a three-tiered training model. For us to be able to increase the coverage, we thought that we need to emphasize e-learning, and I'm happy to see that WHO has already sort of created that environment for us to be able to expand that vision. And the training, currently, we do it in person. So we do a 5-day training of lectures that is coupled with ongoing mentorship. So this is how we implemented our training, and we're seeing quite amazing results. So next slide, please. As I said, noted that it's important to focus on the data system. So a lot of investment has also gone into developing data systems that can provide us with real-time monitoring of what is being implemented in these sites. And we have also integrated core clinical quality indicators within the system so that we're able to track this. Next slide, please. Okay, so now I'm going to revert back to the national implementation, and I will walk through, if you've seen the guidelines that were shown. So there is a implementation framework, the WHO implementation framework. So I'm going to present my next slide, focusing on what is being recommended and how countries should implement. So the phase one is assessment and facility readiness. As a country, we have 2 model sites that are now fully operational. So we completed, this is way back, completed assessment of the infrastructure, service readiness, and workforce capacity at these facilities, and then also conducted a SWOT analysis while developing the national operational plan, so that we already know what we want to do if we want to expand this nationwide. We also have an inventory of available resources, and we have determined what are the potential gaps. So we have this information and actually now know where we want to go. In terms of the service delivery models, we have 2 sites that are currently operating. You've seen all these beautiful pictures here at the conference. So that is, most of the pictures are from our Kondoa site, which is here in Tanzania. So we have 2 sites that are fully operational. But also, in terms of the sites for scale-up, Ministry of Health, when they saw the outputs from the 2 clinics, they were encouraged and actually decided to expand the services to 96 district hospitals. This is 52% of the districts in Tanzania. So they did the baseline assessment and also started training of the health workers. And as a country, we have evaluated the implementation at the 2 sites, and we have reviewed together as a country the training modules that we have, and adapted it to our local guidelines and policies. So that we already have, and some of the guidelines for sickle cell diabetes and rheumatic heart disease are already in place and are adopted also to align with the national guidelines. Next, please. In terms of continuing now with the service delivery model, so we tailored the model to the local needs. It wasn't. We're trying to see from the pilot implementation now to national scale up, some level of adaptation is needed to make sure that it can work in real world settings. So that's what we mean with the steps 6. And that already has been done in Tanzania. And the training has been done to more than 200 staff from the 96 clinics. And we also have additional 98 clinicians that were trained at the 2 model facilities. So we have more than 300 healthcare workers that have been trained. And then we have rolled out the services, but I want to be a bit clear. We are doing detailed monitoring in the 2 pilot sites, and we're setting up the frameworks to be able to monitor the services in the 96 additional districts. And these 96 additional districts, they're now able to provide sickle cell disease and diabetes management only. We have not yet fully integrated the rheumatic heart disease services because of the echo training that is required, and that takes a while. Thank you. Next slide, please. In terms of monitoring, as I said, we have reviewed our monitoring indicators to make sure that the essential PEN Plus indicators are also in the GOHOMIS is the system that we use. I think it was demonstrated yesterday while we were going through the booths. So that system now has some variables that can track NCD indicators, so that is included. And so in terms of now the monitoring, a lot of the information, a lot of the outputs that we know are coming from the 2 pilot districts, and I'll take you through that in my next slide. Next slide, please. So we are on our way towards national coverage. We have coordinated with the Ministry of Health and other stakeholders, and we're working with our colleagues from the NCDI Poverty Network and WHO. So we have looked at what we've learned from the pilot sites and now have a full draft of the National Operational Plan that is currently being reviewed at the Ministry of Health to make sure that it well aligns with other policy documents. So us as technical experts, we've already provided our inputs, but it's really now to see how the national will operate. We don't want to create something in silo, but actually ensuring that it's fully embedded within the national policy environment. And we are working to build more sustainability in terms of ongoing monitoring, evaluation, and adaptation. So we're really learning from the 2 pilot sites to make sure that the design of the implementation nationwide actually is responsive to the local policies and guidelines. Next slide, please. So now I'm going to focus into what we've learned from the 2 pilot sites. As of last month, we have 558 active enrolled patients. So I want to reiterate, this is only from the 2 districts. There's more patients that are benefiting from the PEN Plus services. We have more than 6,000 type 1 patients receiving care in other district hospitals, but this is only focusing on the 2 pilot sites. And we have 200, and this is coordinated by NIMRI and overseen by the Ministry of Health. And we have sites in Kondoa District and Karatu. So we have 247 patients at the Kondoa and 311 patients at the Karatu Hospital. So when we started the clinic, the numbers were much lower. And with severe conditions, I would say we might want to see thousands, but I think even one case is very important when you're talking about saving people's lives. And what we've seen is that we have been able to reduce referrals to the higher level facilities by 80%. So what happened, these patients were not at the district level facilities, because when they went there, they were being referred to the higher level facilities. But if you go to the higher level facilities, these patients were not able to make it to the higher level facilities. Or some of them will go to the regional level and the zonal level facilities, they will go once and then not be able to go back because of the out of care costs that are involved for them to be able to attend those clinics. But we also have to understand that with NCDs, they need to be followed up regularly. So it meant that if they were to go for those clinics, then the children will have to miss school. They will have to, the parents will have to stay away from the economic activities. So really, these patients, most of them opted, so we have data from a separate study, they opted to just some of them get their medication from the local pharmacies, and they were not being seen at any of the chronic care facilities, and they will only appear at the hospitals for admissions when they got the conditions exacerbated. So this is really important that they were able to be retained in the clinics and reduce the referral by up to 80%, and most of them were able to be seen at the district hospital. Next slide, please. So I just want to go back. My colleague will present more on what outcomes we have with our patients with diabetes, but I just want to show what experience we've had with the patient that we've involved in care. So most of the patients at baseline, they had an HbA1c level of more than 12%. The mean was 12.6. So for those working in diabetes, they know what that means. And then at 6 months follow-up, the average was 9.8. So they kept improving. And at 24 months follow-up, most of them had actually had good A1C targets. So for us, this is really an achievement. So we had 5% control at baseline to 39% control at 24 months. So this really is impressive. Thank you. Next slide, please. So I just want to bring it to a personal level, because we might not appreciate it more as an aggregated data, but I just want to give an example of this 20-year-old female patient from Kodoa. Before being enrolled at the Pine Plus Clinic, this patient had hospitalizations like once a month, so was a regular at the inpatient clinic, had on average about 4 DKA episodes, and she was absent from school 9 days, an average of 9 days a month. And then after being enrolled at the Pen Plus Clinic, this patient has not been hospitalized again since enrollment, had 0 DKA episodes, and is able to go to school and has 0 absenteeism from school. So this is really, this is what Pen Plus can do at an individual level if done correctly. So next slide, please. So I just want to also delve into what we've been able to build as an accountability framework. So I took this from a while ago. So this is the system that we have operating at the 2 districts, and is able to, we're able to track all the indicators, but what we have done also is to include social indicators, because with NCDs, as I said previously, we have to also understand their social environment, the socio-economic environment, and what other challenges that the patients are facing to be able to provide good support to the patients. And so then we are also tracking the number of, because we deal with a lot of children, so we track how many days they've missed school. And we track the average distance, and most of them travel around 25 kilometers. This is the referral level, that's why it's 25, but we have facility within 5-kilometer radius in the country, but because they need this referral, so the district hospital is a bit farther, and most of them travel around 25 kilometers, and then takes about an hour to get to the clinic. and that is the average cost of transportation. So we try to find out whether they can afford this or they need additional support. So accountability framework, and this really helps us to when they change, when we see them going down, we can start to follow up and see what is needed or what further support is needed at the facility level. So we use this and we present this to the district health management teams so that they're also able to understand what is happening in the St. Louis country. Next slide, please. We have also built an accountability framework for the mentorship program that we do. So we have built also a system, and this is homegrown system to track the mentorship visits and also to track to track the performance, and we have it sets the we set what the trainees are to be trained on, and then they also tell us what their needs are, where they feel that they need more training, and then also the mentors are able to deliver the training, to assign, because they know the mentees that they're working with and what competencies they need, so they can assign a competence that needs to be trained. And both the trainee does their own self-assessment and the trainer does the assessment as well, and we see how those two converge, and we can also see which modules these trainees have problems with, and then we can do refresher trainings on those. So this really helps us to track progress. Thank you. Next slide, please. So in summary, as I conclude my presentation, what are the key achievements and major outcomes? We have been able to do policy integration. As I said, we have worked closely with the Ministry of Health, and now we are working towards adoption of the NOP. We have the two fully operational Pen Plus pilot clinics that also will serve as a model and continue to serve as model training sites. We have developed, adopted the clinical tools and training to align with our local guidelines as well. And we are going towards service expansion. As I said, we have reached, expanded to 96 more districts, and we hope very soon we're able to have, once the NOP is endorsed, to go to all the districts in the country. Next slide, please. We are working towards integrating Pen Plus into routine service delivery models, and we have initiated partner coordination within the country, because we know there are partners that are working on sickle cell disease, they're working with diabetes, they're working mental health. So we have initiated a coordination system so that we are all aligned, and we are working towards expanding the supervision and mentorship framework to include the other 96 districts. Next slide, please. So what are the challenges? I know I talked about coordination. So we need to have a comprehensive implementation and national ownership for support and follow-up. And this, I think, you can see even in our timetable today, we have a national dialogue. So that is to address the first element, resource and capacity gaps. So we're working on that as well, as the Ministry of Health has taken this on board. And then service delivery for rheumatic heart disease, we need to have more capacity built for that, because then that needs more training and more close supervision and mentorship. And then monitoring and evaluation, this needs to, we'll continue with building our routine system, because the one that I've shown you, that is outside the routine. So that's what we're working on, to make sure that that is fully integrated, and we're able to do that. And we're working also on community awareness to increase the demand for the services. Next slide, please. So what are the lessons that we've learned? I think this is my last slide, I promise. So early planning and coordination. So the engagement of the Ministry of Health, the local government authorities, and stakeholders is the key elements in the success that we're seeing in implementation of PEN Plus in Tanzania. And Tanzania embraces a multi-sectoral collaboration, multi-sectoral approach. So we continue to do that, and we're being led by the Ministry of Health. And then continuous capacity building, we're working on that. And effective monitoring and evaluation, we've already started with the M&E team at the ministry, looked at the indicators, they've started working on it to make sure that they're embedded in the system, and then policy integration and sustainability. And we are lucky that PEN Plus, as we are expanding PEN Plus, the country has already passed the UHC bill, because we know with NCDs, the main challenge is financing. So we believe that this is the opportune moment for us. And most of the basic services that we need for PEN Plus are actually included in the basic package for UHC in Tanzania. Next slide, please. So the national operational plan and the rollout, the targets, I've already talked about this, so I'll go to the next slide. To reiterate more about the domestic funding, and a lot of these will hinge on the UHC plan, and also resources can also be leveraged from the local council planning. So we believe that this will be the cornerstone as we talk about the two-tied financing model. So our local funding will hinge on the UHC, and we look forward to the funding enhancement also from the donor community, so that we expand the NCD services. And I would like to take this as my last slide, and thank you for listening.
Thank you very much, presenters. And I'm guided that time is not on our side, so we will probably pack the questions, but don't write them down, and we'll ask them later. So we basically heard about what the vision of PEN Plus is, the targets that we have set by member states, and how far we have come along that journey. We have as well seen how translating the vision into action looks like through the work of NCDI Poverty Network, and a very good example of what success looks like in the case of Tanzania. We give these people a big round of applause for the wonderful job done. So you will ask your questions, and please write them down, and I think they are here to ask. And also one request is Dr. Yuka, seated behind there, will be interested to see that you scan that WHO academic course link and then provide inputs. If you have any questions, please reach out to Dr. Yuka. As well, the QR code for the products of NCDI Poverty Network. Thank you very much for being very attentive audience, and asanteni sana.
Thank you. One more round of an applause. Thank you for a great job. And thank you, Joseph. My colleague is also called Joseph, like me. Consider him the original. I think I'm the generic, given the kind of work that he has done. A great job. Thank you so much for the journey. Dr. Kofi and Neil exemplified a proverb we have here in Africa, that if you don't know where you're coming from or where you're going, I don't even think you're going anywhere. So Kofi told us where we are coming from, and not Kofi, Dr. Neil, and then Kofi told us where we are heading. And then Mary, my friend, has talked about the successes. It's not just a random intervention. Coincidentally, when I was coming from the airport, the taxi I was using was on a radio station that was commemorating, I think, the 10 years anniversary of the Benjamin Mkapa Hospital in Dodoma, I think. And the CEO there, Dr. Makumi, was talking about the challenges that are top on their list. And I was surprised to hear about type 1 diabetes, sickle cell diabetes. It warmed my heart to hear that while they are few, they don't fall in between the cracks. If there's anything that exemplifies the spirit of the SDGs, that you don't leave anyone behind, it is the PEN Plus intervention, and most of all, what we are doing. So we'll go to the next session. I will be representing Dr. Jones Masia, my friend from EXA. He's not able to make it, but I will represent him today. And we will then take questions afterwards, including the ones that you have asked for this first panel. So for the second panel, I'll try and squeeze it in. We have it more of a discussion so that we can take some questions from the first session. So for the second session, I have three eminent colleagues, and I'll call them up to stage. I will start with Dr. Brown Congo from Malawi. And Malawi is another country that has done a great job. Tanzania and Malawi is right ahead at phase 4 of implementation of the PEN Plus. And Dr. Kogo will be telling us about what they're doing right. And we'll be talking about mentorship and the PEN Plus providers at the country experience in Malawi. A hand clap for Dr. Kogo. Thank you. The next one will be from Ethiopia. Ethiopia is also another country that is doing very well, and here we'll be looking at partnerships across the PPP model. And here we will have a colleague from the Matthews Wondu Foundation, that is Dr. Mulugeta, that will be talking about how they are working together with the NCDI, and they are training a master's training program for clinicians training, and we'll be hearing about how do we build the capacity as one of the interventions. So Dr. Mulugeta, welcome. Oh, yeah, there you are. And finally, we will have the dean at the University of Rwanda School of Nursing. We have Professor Olivia Bazireta, who will be talking about their initiative of training and nurses. And at the tail end, we will have realized the value of nursing and nurse-led care for NCDI and also for PEN Plus interventions. So she will be talking about what they're doing, the pre-service training that they're doing in the University of Rwanda School of Nursing. So Professor Olivia, welcome. Thank you. Right. Okay. So I know they have 15 minutes to present, but we have already discussed with them. We'll try and squeeze the presentation so that we have more time to discuss and have a one-on-one, and we'll also have an opportunity for questions from the plenary. So if you could load the first slides for Dr. Brown, he will come and talk about mentorship for PEN Plus providers, as an experience from Malawi. Dr. Brown.
Good morning once again. So I'm Dr. Brown Congo from Malawi. We'll talk about mentorship, which is part of the workforce development pillar, specifically sharing experiences from Malawi. Next slide. Next slide. Next slide. Yeah, but before we go straight to mentorship, I just wanted to mention that mentorship program did not start in vacuum. Neither was the PEN Plus initiative in Malawi. Before we started with PEN Plus, Malawi had been implementing the LRT program, as many countries have been. And specifically, the NCD work was more consolidated in one district where all this started, where the Ministry of Health is co-implementing with Partners in Health, a district called Neno. And we started really by leveraging the LRT program, which was working very well at that point. That gave us a platform to build a longitudinal care program where we integrated non-communicable diseases within the LRT program at primary care level. This meant that we are managing both infectious and non-infectious conditions, chronic conditions in one clinic, which also meant that we are leveraging in terms of patients, in terms of patients' visits for comorbidities, so as to limit some of the costs that are incurred by the patient. Also, we knew, as we all know, that Sub-Saharan Africa, including Malawi, we have a huge gap when it comes to human resource. So we realized that building a vertical NCD clinic was very impractical at that point, but we needed to leverage the resources that were already there. And being the initial phases, we also needed to go out and look for the patients. So we introduced intentional and active case finding programs where we are screening at the community, in the facility, and even intentionally looking for NCD cases within the inpatient wards, which are abbreviated as SHAC, SHAF, and SHARI. which is actually screening for health and referral at the community, screening for health and referral at the facility, and screening for health and referrals within the inpatient setting. Next slide. And then also, we needed to monitor and check how we actually progressing. So we had to start building strong EMR and M&D systems for improvement. And all this was meant for us to look at, the aim was really like to look for an approach or a solution that would help us expedite decentralization and scale up NCD services in the country within the primary care setting. And this also was an initiative to strengthen the primary health care, which we know is the main vehicle for us to realize the universal health coverage. As I mentioned, that provided us a platform to start implementing mental health services like MHCAP, WHO MHCAP, the WHO PEN, and now PEN Plus models. All these were leveraged within the initial clinics that started with ART. This, as I'm sharing today, we are able to manage WHO PEN in all the 29 districts in Malawi, healthcare districts in Malawi. And for PEN Plus, around 2018, 2019, we started with 1 district, and we managed to scale up. Now we are talking about 12 districts that are implementing PEN Plus in Malawi. 2 were trained about 2 months ago. Then we have funding now for 3 more sites. By the end of 2026, Malawi will have hit 58% coverage for PEN Plus scale up. And NENO remains the training center of excellence for that, where we capacitate the mid-level providers and also producing local mentors within the mid-level providers. Next slide. So why mentorship then? I think I wanted to say that in the setting like Malawi, and pretty much maybe in most sub-Saharan Africa, mentorship is non-negotiable. Pretty much because we don't have specialists, to say the least. My colleagues here, I think they will share later, like how many subspecialties do we have in Malawi? Probably, I don't know the percentage because I can't say it. So we need to work with what we have, and therefore working with the mid-level providers of clinicians and nurses. These need to be supported. And then also these providers, most of them, they are trained for 2 years or maybe 3 years. So they don't really have the capacity at that point when they're entering the system to manage these complex and severe NCDs. That's why we need to follow through with longitudinal mentorship. And then also we are noting that there's a high burden for these severe NCDs, type 1 diabetes, sickle cell disease, rheumatic and congenital heart disease. So like I said, this is a non-negotiable intervention that we need in this setting. Mentorship so far has seen to help us in improving the quality of care in these settings, because it does provide ongoing clinical support. It does reinforce practical skills and improves competencies for the providers in this mid-level, the mid-level providers in this resource constraint setting. Next slide. So the model that we are using at the moment in Malawi, and here we just summarized and briefly because of time, like I mentioned, we're working with different levels of cadres, because like I said, we don't have the specialists. So on one side, we need to build a team of mentors. Like one part that we have done is to train and identify selected clinicians and nurses that received the PEN Plus training for 5 weeks and later on followed up with training for the actual mentoring approaches. We also working with specialists at national level from the tertiary facilities that provide support in these peripheral hospitals, internal medicine, pediatrics. I should also mention that we are also working with external colleagues and partners. The Center for Integration Science becomes very high on that. And a picture that you see there is Dr. Mata, there is Dr. Colin, that came to Malawi last year when we were doing actually mentorship training to build more mentors within the clinicians and nurses that are providing care. It's a hub and spoke model, meaning we have tertiary facilities that support the peripherals, but also we have selected districts where we have these clinicians that have received advanced training and support the neighboring districts to provide that mentorship. And all these are from the Ministry of Health, because that's the only way we're going to sustain this in the long run. And we are doing both on-site and virtual. So for the on-site, at the moment, we've started with our monthly visits, like similar to Tanzania. And probably after maybe 6 months or so, maybe we'll go to quarterly, also learning from the Tanzania case. We mostly focus on case reviews, seeing patients together, reviewing the data, and using the gaps that we identify through data reviews to set up quality improvement initiatives. And then also that's a good platform for the mentors to start looking into other critical issues like supply chain being the biggest challenge that we have in our setting. And that plays a ground for advocacy too. So these mentors also advocate locally within the facilities, talking to the district health management teams, but also escalating that higher into the funders. Virtually, we have WhatsApp platforms, easy. Almost everyone has a WhatsApp on their phone, and we are able to connect with the mentors, the mentees, and even external supporters like the team from CIS. We're doing teleconsultations because we can't have cardiologists, and we don't have cardiologists in the districts, for example. We don't have endocrinologists in the districts. We are able to connect through these platforms to consult for complex cases where we are not very clear. And that also is followed up with professional development courses. Next slide. So with that, what we have noted is a few more successes that we have registered. There could be many, but we'll share these. So one is really improved clinical capacity, like I said. We are talking about providers that maybe were trained for 3 years. And we know med school takes about 7 years or so, but these are 2 to 3 years training. So we have seen improved capacity to the extent that now we are able to manage type 1 diabetes, sickle cell, and rheumatic heart disease within the district hospitals. And now we are talking about 14 districts and going toward all the districts. The care is decentralized. We have reduced the cost from the patient side. It's still high, but not as high as it was before Pen Plus. Referrals are reduced, meaning we have decongested the tertiary facilities. Now they can focus on complex conditions, and they can also focus on other initiatives like training, because these are also training institutions in as far as they provide care. Patient outcomes have improved, and as Tanzania case shared, it's not just about the numbers. It's not just about the HbA1c. It's actually the improvement in the quality of life, the translation in terms of what does it mean to reduce hospitalizations to the family. Actually, it means building someone who would be productive in the future. Because now they are in school, these kids are in school. They used to stay in the hospital, now they're staying with their families. So the outcomes really are beyond the numbers that usually we discuss in a platform like this one. And then the healthcare system is strengthened because we are building this bottom up, starting with the primary care facilities and going upward. Next slide, please. Nonetheless, that does not mean that the journey has been smooth. There are still some challenges which will need us to continuously collaborate and work together as partners, but also with the national ministries of health. The first one needed is on the actual staffing. The vacancy rates are high in our settings, but also sometimes we see high staff turnover. You train providers in Pen Plus today, an NGO comes and recruits them out of the Ministry of Health, and then you don't have them on the ground anymore, for example. Leadership and governance. We still see some verticalization when it comes to funding and donor or funder priorities, and that really brings more challenges because we don't have the resources for us to run parallel programs in Malawi. We would need to consolidate all the resources and be guided by the priorities of the ministries of health in Malawi and other countries too. We also noting that it's easy to train people for 5 days. You can actually, the funders would fund that easily because by the end of the week, I'm going to submit a report that Malawi has 2,000 Pen Plus providers, but most of them, they don't know what they're doing unless you follow through with mentorship. And this is the problem we have because most funders, they are resistant into funding mentorship because they think it's expensive, it takes longer, but good things take long. So we're still pushing, and this is where we need to collaborate very well in terms of mentorship programs. We have inadequate resources. We don't want to train people and mentor people with substandard resources. We don't want to train people to use HbA1c, but we don't have it during the training. You can't demonstrate because it's not there, then it doesn't really help. So when we improve the supply chain, it's not just for the patient care, it actually helps also to improve the actual training package. Spaces, we can't say much about that. It's a big problem, but we are making the tax shift. We are using the spaces we have because we need to start with what we have, but we would love to improve those spaces. Sometimes we don't have a consultation room that can accommodate a mentor, a provider, a patient, and the caregiver. There's no space for 4 people because the consultation room is very small, and it was probably a stores room at one point, and someone just converted it because the need is high on the ground. And then we still see, like I said, verticalization. Donors still come and fund a parallel program. So you go to the hospital, which have a fancy ART clinic space, but does not have an NCD clinic space. Do we continue with that? I will leave that as a question. And of course, social support becomes key. Even if we decentralize, we still have vulnerable populations that are still not able to access these services. And we need to come in and alleviate that level of poverty. Next slide, please. And I think this could be my last slide. Just sharing a few lessons from Malawi, but also how we envision the future together with the Ministry of Health. One thing that we have learned, like I mentioned, is regular mentorship is more effective than funding a 5-day didactic lecture, classroom-based training. We'd want to move toward that. We can reduce the number of days for the actual didactic trainings as long as we invest in mentorship. We could incorporate these lectures in the pre-service training, but that does not substitute mentorship. Task shifting is working, but needs to be supported by strong supervision and leadership on the ground. Peer-to-peer mentorship is working, but again, we also need support from the specialists, from the tertiary facilitators to support that. Government ownership is central. Malawi has reached this, talking about 58% by December, basically because we are building this in the system that is already existing. This is the Ministry of Health system. If the government doesn't own, it doesn't matter how much resources you have, it's not going to work. And digital platforms, like I mentioned, as simple as WhatsApp, have seemed to be cost-effective and impactful when it comes to mentorship. The future, we are looking at scaling up the Pen Plus mentorship to the remaining facilities, integrating Pen Plus mentorship into national health systems, so it doesn't come as an activity, but it's part of the institutional program where the Ministry of Health is spearheading, not mentorship as an activity. And then expand use of telemedicine platforms so that we are also tapping the knowledge from the other countries, not just the West, even within the region. We can tap from Rwanda, we can tap from Tanzania and other countries that are implementing Pen Plus. And then develop a more local mentors. Like I said, we do not have more specialists. So we'll continue to develop more mentors within the middle-level provider cadre. And then strengthening the monitoring and evaluation systems so we are able to track and be able to respond to the challenges and the gaps that we identify on the way. Thank you so much for your attention. This is where we end. Thank you so much.
Thank you, Dr. Brown. I love the passion with which the two countries have presented themselves, Malawi and Tanzania, and you happen to be the two front-running countries that are, doing this. And I see colleagues who joined us. I see Prof. Jean Bachman, you are with Professor Anna, I think the father and mom of NCDI or the Pen Plus movement. We appreciate your support. And for Malawi, I see your WR here, very supportive. WR, good friend of mine, embraces the concept of mentorship as we talked about it, and an epidemiologist by excellence. So please utilize them, and I know we will be following up on Malawi. And I know you talked about the fatigue that we experience in government where you train and the trainees leave. One of your countrymen, Dr. Kalua, who was just the immediate former WR for Ethiopia and also was my WR in South Africa, said one time that we might be worried about training people and they leave, but we should be more worried of if we choose not to train them and they choose to stay, which is the bigger problem. So we still train anyway, because I think it makes sense to still train. Even if they move to another NGO, they're still serving Malawians. So don't panic about that. They're still in service. So the next we'll be hearing from Ethiopia. And coincidentally, we'll be talking about capacity building and training at a master's level to see how to build the capacity for the Pen Plus master's training for clinical training. So Dr. Mulgeta, welcome.
Okay, thank you so much. For the next 10 minutes, I'll be talking on a very important topic on Pen Plus. That is Pen Plus Master Training and Clinician Training. I will be sharing my experience from Ethiopia. Next slide, please. Okay, before diving to the detail, in Ethiopia, the Pen Plus providers are a multidisciplinary team consisting of general practitioners and nurses. Both have their well-defined roles, but they are complementary to each other, and they are also a dedicated and non-rotating providers at the clinic. Next slide, please. So before providing the training, what we do is we collect our expertise and establish a Pen Plus technical working group, and we adopt and designed our training framework. Then we adopt also training material from the NCDs covered network materials. So these are how our training framework looks like. We have around 3 or 4 pillars of the training within the mentorship. Next slide, please. So the first and initial Pen Plus training is a foundational training. This is the basic and a very important training that we provide to build the capacity of mid-level providers at least to initiate the service at the clinic. So what we did was we select the candidate based on some criteria, and then we make them to sign an agreement with the government at least to give the service for 2 years after the training. And this training took around 4 weeks. The first week is for classroom-based training, and followed by 1 week of clinic attachment. And additionally, there is also 2 weeks for point of care echocardiography. So we have totally trained around 14 providers. The number looks small, but this has very big impact. So after the training, we have also a post-training mentorship, which is also part of this training. Next slide, please. So after the training, after there is a mentorship, which is well structured using a checklist, and based on this checklist, we will continue the mentorship till they build their capacities or the competencies that we expect from them based on the Pen Plus conditions that are treated in the clinic. So once they finish their logbook, so we declare as they are fully trained as a Pen Plus providers. Next slide, please. So the Pen Plus capacity building training is competency-based training. So what matters is not the duration of the training, rather the competency is the most important thing. So our goal or aim is reaching the top level of the Miller pyramid. That means the providers have the capacity or the ability to do all the tasks that are expected from them. So we need to ensure that they have these competencies. So to reach the top of the pyramid, we have to pass through different phases, starting from the classroom-based training, then clinical attachment, and followed by continuous mentorship till they build all their skills to the level of competency. So at this level, we can define it as they are fully trained, and they can independently practice. They can also practice safely. They can provide safely on the service on the patient. So far, we have 4 providers who have completed their mentorship logbooks. The others are still under the mentorship. Next slide, please. So the other important training pillar is master training. So from the first cohort of 10 plus trainees, we selected 4 providers based on their dedication and similar to the basic training, they are also expected to sign an agreement to provide service in the clinic for an additional 2 years and also supporting the scale up through training and the mentorship. So after this, we gave them a master training. So we have also clearly put this in our national operational plan. Next slide, please. So the master training is very important package of 10 plus training. The reason we need a master training is because we have already launched our national operational plan. We have a plan to expand the 10 plus service to other hospitals. So we can't afford moving the busy specialists and the subspecialists to the district for training and the mentorship. So that is why we need master trainers. And the other important thing is during the rapid scale up and the massive training, the quality of training also might be compromised when we always depend on the busy specialist. So compromising the training means directly we are affecting the quality of care and as well as the safety of the patients. Next slide, please. So by the foundational training and the mentorship, already they have built their clinical competencies. But to be a master training, there are additional important skills that are required. And the content of this master training includes like how to teach their peers and also how to mentor and how to give a constructive feedback or assess the trainees for improvements. These are the most areas of the master training curriculum. So we gave this training for 8 consecutive days, and this is how the curriculum of the master training looks like. Next slide, please. So the other very important thing is, which is equally important as a master trainer, is the training centers. One, go back, please. Yeah, training center is also very important. So we have established 2 training centers, which are the 10 plus facilities. They are accredited. So in the next scale up, we are using the clinic for the practical attachment. We have also established a room for class-based teaching or learning. Next slide, please. So my recommendation is for the ministry, first we have to have a clear plan, including a cost for the training scale up. We have to also adopt our training material based on our context. And if we have an accreditation system, we need to accredit our training materials. And we have to also establish the mentorship activities. And for other implementing partners, the other important issue during scale up is the quality of the training. So we need to ensure the quality of the training, and the development partners are also expected to support countries through the technical guidance, through the finance and other important technical aspects. Next slide. So this is my last slide. For PEN Plus succeeds when providers are equipped with the competencies and the confidence needed to provide high quality severe and CD care. And the training has to follow competency based. It has to be multidisciplinary and it is longitudinal, as you have seen. And the training has also need to combine didactic with practical attachment and followed by the mentorship. These are very important. And the master training is the backbone of scale up. And additionally, don't forget to ensure the quality of training during the scale up. Thank you so much.
Thank you, Dr. Mulugeta. Very interesting concept on mentorship. And indeed, as you said, it's the backbone of scale up and sustainability. When you hear about these models of training, one wishes and wonders, what if these nurses, when they came from nursing school or from university, already knew about Pen Plus model? What if the doctors like myself, when we were in medical school, I know Dr. Coffey talked about the targets that we have, that by the time we are in 2030, all countries will have robust mortality measuring data. I wish somebody would have even taught me about filling a death certificate when I was in medical school. You learn it when you first meet your past mortality. That's how you learn how to write the death certificate. And as an NCD community, we lose a lot from clinicians not knowing how to fill the death certificate. Somebody dies of HIV, but just because they have HIV in the file, the guy had a stroke, maybe not related to HIV, but the death will be captured as a HIV mortality, ignoring the secondary two and secondary to number C, which probably would have been hypertension, got bad, and then he had hypertension and had a stroke. So to just bring the full circle around, we have Professor Olivia, and Professor Olivia teaches at the nursing school and trying to build the capacity even before these staff get into the field. And as you present, Professor Olivia, one of the questions I want to have at the back of your mind is, Pen Plus, of course, relies heavily on nurses and nurse-led care. But just one slight challenge that we have is it's not a conflict, I won't call it a conflict, but just the tension between regulatory boundaries and also the workforce needs. We have the Nursing Council that has its regulatory boundaries. We are now pumping nurses with new skills for Pen Plus and expanding the boundaries. So how will this framework sometimes restrict, and how do we go around it even as we're training our nurses to be able to be useful, but also keep within the boundaries of the regulatory framework? Professor Olivia.
Thank you so much. While they are putting on the slides, good morning. I'm Oliver Vazirete. I'm Associate Professor of Midwifery and the School of Nurse, the Dean of the School of Nursing and Midwifery at the University of Rwanda. Today, we share Rwanda experience in developing a sustainable workforce strategy for the non-communicable diseases through a creation of a Masters of Nursing in of Science in Nursing, focusing on NCD management. Next. This is the outline of my presentation. Next. As previous presenters has already highlighted the statistics about NCDs at global and regional scale, it is important to remember that NCDs remain the leading cause of death and disability worldwide. They pose a major threat to achieving the Sustainable Development Goals by 2030, with the greatest burden falling on us in the low and middle income countries. Next. As it is already known, 4 major disease groups account for nearly 80% of premature NCD death worldwide. And in 2024, NCDs accounted for nearly 48% of all deaths in Rwanda. This means that almost 1 out of every 2 deaths is now associated with NCDs, highlighting the urgent need for a strong and well-prepared workforce. Next, please. With the support from the NCDI Poverty Network, the Rwanda Ministry of Health pioneered the PEN Plus model more than a decade ago to address the growing burden of severe NCDs. As indicated by our Minister of Health yesterday, Dr. Saben, it is now 20 years ago. PEN Plus now expanded specialized NCD services from referral to district hospitals, bringing care closer to rural and underserved populations and improving access to treatment. This initiative has significantly strengthened NCD care delivery across the country. However, implementation challenges remain, particularly the need for a sufficient number of highly trained healthcare providers to sustain and scale up these initiatives. And these challenges highlighted the importance of developing a sustainable workforce strategy to support advanced NCD services in Rwanda. Next, please. Nurses so far have played a central role in Rwanda NCD response. Since 2016, nurses have been providing NCD care through PREMPAS services in all district hospitals in Rwanda. And beginning 2021, NCD services were further expanded to health centers, significantly increasing access to care. At the health center, the management is so far common and tackling hypertension and diabetes. However, several challenges became evident despite the success of PEN Plus. Important workforce challenges remain. Nurses' retention is low, and the expanded role of nurses in NCD care is not always formally recognized. In addition, there's no accredited academic pathway for NCD nursing specialization, with most training being informal and on-site. And this highlights the need for a more sustainable solution. Next. To address these challenges, the School of Nursing and Midwifery at the University of Rwanda, with the support of the Ministry of Health, we partnered with the Center of Integration Science to develop a Master's of Science in Nursing, focusing on NCDs management. Here on this photo, we see the team from the University of Rwanda and a team from CIS, the Center for Integration Science, some medical specialists in a workshop in Kigali to review this program. Our objective was not to train nurses, but also to create a nationally recognized specialist in nursing pathway. The program is currently undergoing final accreditation at the Higher Education Council. This marks an important milestone because it shifts NCD workforce development from informal training toward formal academic preparation. Next, please. Before designing this curriculum, we conducted a needs assessment, and it was comprehensive. It was involving nurses, hospital leaders, policymakers, and the other stakeholders. The findings were very encouraging. Nearly 98% of participants identified nurses as the primary providers of NCD care. These findings providing strong evidence that the program would respond to an actual workforce need rather than a perceived one. The needs assessment also guided the curriculum content and implementation strategies, because we're addressing questions tackling on different methodology. What type of methodology do you think would be suitable to deliver this program? Next, please. The curriculum development involved extensive collaboration and consultation. Multiple workshops were held with nurses, educators, clinicians, medical specialists, policymakers, and professional bodies. And the curriculum was endorsed by the the National Council of Nurses and Midwives, and that's what the moderator was mentioning. How do we collaborate with the Nursing Council? It was reviewed also by the external experts. It is successfully passed through all the approval process, starting from the school council, the college academic council, and the university academic senate. It is now awaiting final accreditation by the Higher Education Council, as I earlier indicated. An important feature is the dual exit pathway. Students may graduate with a postgraduate diploma right after the first year of training, or continue into the master's program after 2 years and complete with a master's degree, including research and leadership component added on top of the first year. Next, please. Next. The proposed master's program is expected to generate benefit at multiple levels. First, it will improve retention and motivation by creating clear professional development opportunities. Second, the graduate will receive nationally recognized qualifications, strengthening professional recognition and career advancement. Third, the program will strengthen integrated NCD care throughout the health system, from primary care facilities to referral hospitals. Ultimately, the goal is to improve patient care through a more competent and stable workforce. Next. A key strength of this program is its residence model. The curriculum is designed around competence-based learning and practical clinical experience. Priority admission will be given to nurses already working in NCD clinics at the district hospitals, because they are directly involved in residence delivery. Clinical training will take place at level 2 teaching hospitals under medical specialist supervision, and the university faculty will provide academic mentorship throughout the program. This combination of clinical and academic mentorship is intended to ensure that graduates are both clinically competent and academically prepared. The first cohort is expected to start in September, next September 2026. Next, please. This initiative highlights several key lessons, particularly the importance of a stronger collaboration between the Ministry of Health, the University of Rwanda, and implementing partners. A structured needs assessment ensured alignment with real workforce and the service delivery gaps, while the competence-based residence mode strengthened the clinical preparedness. Moving forward, the immediate priority is the final accreditation and the launching of the first cohort in September 2026. We will also closely monitor program outcome to assess its contribution to NCD service delivery and workforce capacity. In the long term, this program provides the foundation for expanding advanced nursing specialists, and strengthening recognition of specialized nursing practice in Rwanda. Next. In conclusion, Rwanda experience demonstrates how identifying a workforce gap can lead to a sustainable educational solution through strong partnership, evidence-based planning, stakeholder engagement, and institutional commitment. I thank you so much.
Thank you, Professor Olivia. Time is really not our end, on our end. I will take maybe one or two questions or a comment in each of the rows. Please direct it to any of the panelists here or the panelists in the previous session, Dr. Mary Maige, Neil Gupta, and Kofi Nyarko. Those with roving mics, please, is one here. Please make it very brief. Don't make a presentation. Just go directly to the question that you're asking. Kindly. Can try and project your voice as they.
For the great presentation. My name is Dr. Symphorian Kambo, and I am representing the World Rehabilitation Alliance and the International Society of Physical and Rehabilitation Medicine. So my first question goes to Dr. Congo and Professor Olivia. In your respective training program curriculum, is there any module on rehabilitation to give basic knowledge to these workers, health workers, about rehabilitation interventions? Rehabilitation need identification and some basic knowledge on rehabilitation intervention. This is my first question. My second question goes to Dr. Mary and Dr. Congo from Malawi. In your clinical practice, in the multidisciplinary team that you have on the ground, is there any rehabilitation professional member of the team, for example, physiotherapist or anyone supervising for rehabilitation needs assessment, for example? And how do you concretely need manage patient with rehabilitation needs? And I'm asking this question regarding what Professor Olivia says. NCDs is one of the leading cause of disability worldwide. So I would like really to, or I will appreciate your response regarding these two questions. Thank you very much.
Thank you, Prof. We'll take another one. We'll combine two or three. That's a question on rehabilitation. One of you can prepare to answer it. There was one, is a lady. Yep, right there.
Good morning, everyone. Excellent presentation. Quite happy that you shared all this information. My name is Maya Tigani. I'm technical officer in WHO HQ. And my first question is to Mary, Tanzania. It's about, I noticed that you managed to change the culture in the clinic and create multidisciplinary teams. So what motivated the change? Did you make any change in the payment mechanisms or others that can sustain such a modality of work? And regarding also the training, does once the theoretical training is completed, are the providers able to immediately practice, or there is another step in between? And final question to Olivia. I understand from the presentation that the common condition like hypertension, diabetes, and so on are included. Just I want to confirm that in the training. I want to confirm if you have included common NCDs, and will these nurses also practice at primary care level or only district hospitals? So that is all.
Thank you. This middle one here, so that we don't get accused of neglecting the middle on the left side there. The lady right at the back there who Almost getting a shoulder dislocation, lifting her. Right there. You can stand up so that they can see you. Okay, there you are. 2 questions here, then 2 questions, and then we will answer them. Unless it's a very pressing one from this side. Allow us to take from this side. Go ahead.
Thank you so much all for your very insightful presentations. My name is Atwaile Tabitha. I'm from Uganda. I'm a founder of a CBO, apparently working on mental health. As we appreciate the work that Pen Plus is doing across the region, I have, as Dr. Mary, my brother from Malawi, as they were presenting, I didn't hear communities being involved. As you all know, these trainings should be taken to the grassroots because those are the people who are most affected. For example, I'm going to pick one example, cervical cancer. As you all know here, cervical cancer is among the cancers which can be treated when detected early. But due to late detection, level 3, level 4, 67% of cervical cancer cases in Uganda end in death. So as Pen Plus, do you have any interventions for the community? Thank you so much.
Thank you, Mary. Tabitha, mental health was not mentioned. I didn't hear it, and communities and involvement. One question ahead of you, then we move to that side. Please make it brief. Go right to the question.
Thank you. I'm Dr. Nasra from Tanzania. I'm a medical doctor here. I just had one question for Dr. Mary. One of the key challenges were the incorporation of the NHIF. So I wanted to ask, is there any talks before or any progression on incorporating the insurance for us to reduce the out-of-pocket money for the patient? Thank you.
Great question, Mary. Please take note. National Health Insurance, that end. Please do the selecting of the question so that I'm not accused of avoiding any of my friends. Most of them are my friends with their hands up. So just give any 2 from that side.
Good morning, thank you. My name is Adiso from Ministry of Health, Ethiopia. I have one question for Dr. Kofi. I think he mentioned one term which is blended financing model. I am not clear about the blended financing model, just to be clear about this term. Thank you.
Thank you. Final one.
Good morning, everyone. My name is Margaret Justin. I'm a cardiovascular nurse from Jakaki Kikwete Cardiac Institute. Actually, I have questions to Mrs. Olivia B. Tezere from the University of Rwanda. I have 3 questions actually, but I'll be very brief. My first question is, you mentioned that you're planning to start a Master's in Nursing program focused on NSD management. How long will this program be? That's my first question. Will it be fully funded by Pen Plus? That is one of the first question. And the second question is, you mentioned in your presentation that most of the NSD patients are reached out and provided care by nurses. But you also mentioned that these nurses do not have any formal training. So how do you ensure safety of these patients? And how do you facilitate reliability of the diagnostics since most of the NCD patients are mostly delicate? Thank you.
Okay. We'll start with colleagues who are in the first session here. Please pass the mic to Dr. Neil, Mary, and Kofi. Then we will finalize with these guys. That's Mary there, right there.
Oh, thank
Make
you.
it brief, Mary.
Yeah, I'll try. I have a long list of questions. I'll try to address them. The first one was with regard to physiotherapy. So the implementation of Pen Plus, the initial pilots focused on 3 conditions: type 1 diabetes, sickle cell, and rheumatic heart disease. And during implementation, yes, we identify a patient that had several needs. I think if you looked at the video that was shown yesterday, there was a patient that was blind, that was able to be assessed, identified, and was referred. So it wasn't part of the focus, but we are also looking at the different disabilities that the patients have. And we work with our referral pathway to make sure that they get the services that they need. And I'll combine this with the mental health question and the social support in the community. So if you saw my presentation, I mentioned that we are also tracking some social indicators to make sure that they're able to attend school. So if they have any challenges, then we identify those. And we work within the district hospitals. We have the social welfare department as well. So that we use the social welfare department to refer patients that we think need their services. And some of the work that they do is actually to help them identify their resources, and for those that cannot afford to come to the hospital, then they're able to support them through the other social welfare services that they provide within the district, so that they're able to support the family. So that's how we do it. So if we identify a patient that needs further rehabilitation support, we work with the services within, so we really encourage the integrated care. We don't verticalize the care, but we do the assessment, and those patients that require those services, we do provide. With regard to the community, yes, we work with existing programs. In Tanzania, we have a school health program, and we also have outreach programs. So our Pen Plus teams, they work together. So as Pen Plus, we don't implement directly because there's resources that will be needed for us to, and we don't wish to verticalize them. So we work, when they're going for outreach programs, we encourage our Pen Plus implementers at the district to also go. So when they go for the MCH outreach, for the TB outreach, then they'll go and do some Pen Plus work as well. And some of the patients, like the type 1, the sickle cell patients that we have on the program, were identified through those Pen, outreach program. And we've done a school health, integrating with the school health program as well. And we're able to screen our children in rheumatic heart disease areas to be able to do some echoes and identify some kids that were then put into the program. So that's how we've been able to link. There was a question of motivation of staff. So when we're starting, because these services, we didn't have dedicated services. So initially, yes, we had to motivate all these government staff that are working within the facility. So this was a minimum token that was given to them to be able to initiate and sustain the services. It's minimum. It's not a lot, just a minimum to encourage them to continue. And with regard to NHIF, I think I need to, there's not much of a challenge with the NHIF. As I said, most of the essential services, so the way we framed the essential services for Pen Plus in country, we have the minimum, the essential services, and then we have, another desired package. So all the essential services are actually within the NHIF packages. The challenge was that some of the packages are made for different levels of care. So before Pen Plus, these patients will have their cards, but then when they went to that level, those services were unavailable, and then they were referred to higher level services where their insurance cover that they had probably wouldn't be, they wouldn't be able to access those services. They needed to start from there and then they, follow the referral system. So with the integration of Pen Plus services at the district level, it means that they will be able to access those services because they are all within the minimum benefit package. Thank you.
Okay. Dr. Kofi and Dr. Neil. Yeah, there you are, Dr. Neil, and then Dr. Kofi at the back.
Thank you very much. I'll just respond to one question, which was from Dr. Adisu from Ministry of Health of Ethiopia on blended financing. So just to recall from yesterday, we heard the investment case around Pen Plus. So with a call for action of 1% of government health expenditures going to Pen Plus, we believe that we can achieve the regional strategy targets and achieve some low level of coverage of Pen Plus services for populations in need. So with that 1% is essential domestic financing, but a blended model would mean, in addition to that 1% mark of domestic financing, of 1% of government health expenditure, which was established and advocated by the Ministry of Health of Ethiopia within the National Operational Plan that Ethiopia published in January. Blended financing would bring in additional external financing from the donor community to achieve a much higher level of coverage of clinics and reaching many, many more individuals. So we projected that with blended financing, you could reach 3 times more individuals in need and a much more acceptable level of coverage of Pen Plus clinics and patient enrollment. So, thank you.
Thank you, Dr. Ding. Indeed, you can reach more and it's also sustainable. Dr. Kofi, any words before I come to my panel here as we close?
Thank you. I think that my question was still on the blended financing, since it was part of the priority actions for the Africa region. And from our perspective, adding to what Neil said, we said innovative way of financing, using blended financing. There are so many ways to do it because, as you know from yesterday, huge disease burden, but we don't have the much needed resources. So domestic financing, ensuring that governments have a budget line for NCDs. How do we do it? Various governments are doing it differently. We may have a health insurance. We may have to look at taxing alcohol, tobacco, sweetened beverages. In Ghana, for example, they have what we call the VAT, value-added tax, and a proportion of them goes to health. And to me, that is very innovative. And in Ghana, the money that was being collected for health was even more than what was needed for providing care in terms of curative. And this year, the government has come up with free primary health care using that same money, because a smaller percentage of the money was being used every year, whilst others was used for something else. And the president has uncapped it, so there is no threshold. All the money is supposed to be used for primary health care, and still there's going to be still much left for severe NCDs, including cancers. Now there are about 8 cancers in that package, sickle cell and all the major. So each country, based on your system, blended financing, mixed means, come out with various innovative ways to get money to deal with NCDs, because that is our problem and is going to continue. And if we don't deal with it, it's going to be a big problem. We need to bring in the private sector. We need to engage other philanthropists and make sure that there's an eye on finding for NCDs and severe NCDs as we've presented here today. So we don't have a specific package, but we recommend that countries should look at it based on their context and come out of multiple pipelines to fund NCDs in Africa. Thank you very much.
Thank you. And indeed, to keep it integrated within the UHC packages that governments are rolling around, so that we don't create another silo. And it's good that you're talking about this blended financing and always making sure that the governments gives the leadership. Donors and other funders supposedly are supposed to give us some catalytic financing, as we hope that the government picks up and runs with it, because when governments and the people lead, then there is sustainability. Finally, here to my colleagues, I think this mic is working. Dr. Brown, briefly, the 3 of us, go ahead.
Sure. Thank you so much. I'll start, and then my brother here will add in, and then I'll try to give an integrated response, because I think some questions are interconnected. I will enter through the communities. I just wanted to appreciate that yes, the community is very key into the successes of this program, because as we know, like, patients only visit the hospitals, they don't stay in the hospitals. So building a system and structures within the places where they are living is actually key for both identification and retention and sustainability of the programs. The case for Malawi, actually, the Ministry of Health has a cadre at the community level called health surveillance assistants or disease control surveillance assistants that are deployed within the villages, the communities. And part of the roles that they do is actually to support with case identification within their villages. So the systems that we shared about the capacity building, they don't really start with the care workers at the secondary care hospitals. We actually train these community structures. So the HSAs are trained to actually look for the cases. Apart from the actual training, we also provide some basic screening tools. So these are these structures actually have, for example, a blood pressure machine that actually they are able to measure somebody's BPs in the community and link them to care through their nearest primary care facility. Likewise, a glucometer to check the blood sugars and link them to care. So there's work that is actually happening in the community around case identification. I just wanted also to mention that apart from these structures, we also trained and supported peer-to-peer patient groups. So we have patient groups within their communities. They know each other and they support each other in terms of the care that they are receiving. And the same also applies. So for the mental health, we probably did not single it out here, but through the integrated chronic care model that I had shared, which is mostly focusing at strengthening the primary care level facilities, mental health is part of that. And we are actually implementing the WHO MHCAP at primary care facilities. However, when it comes to secondary care, I should mention also that we do have advanced mental health clinics that are actually looking at patients that are living with complex mental illnesses that are managed by trained mental health providers. As the presenters from yesterday and today, they have talked about NCD approach or care to management is a multidisciplinary approach. Even at the secondary care level where the clinics are running, they are not just managed by clinicians and nurses. We have pharmacy team, we have the lab, we have the rehab team. So really we're working together, and even part of the trainings is they are also trained. Like in Malawi, for example, we have trained physiotherapists and physiotherapy technicians that are able to be together and support the care. We also even work with nutritional technicians, dietitians where possible in the facilities based on the availability of these structures. So I just want to mention that even if we mostly focused on the clinicians and nurses in the slides, but actually this is a bigger team than just the clinicians and nurses. So we work together in those spaces because we know that the needs for these patients are beyond maybe just the medical treatment. We're also working with the social support, like I mentioned, so the welfare team to come in and provide support beyond the medical care. Thank you.
Thank you, Dr. Brown. Dr. Mulugeta, please, very briefly, we're way behind time, and then we hear from Prof, and we go to the next session.
There is no specific.
Perfect. My guy. All right. Prof, finally.
Thank you so much, and thank you to participants for asking these questions. The first question was regarding the module that will be delivered throughout this program of Masters of Science in Nursing. Actually, the focus will be the module delivered is through the Pen Plus approach. And these include diabetes type 1 and type 2, hypertension, heart failure, and so on. So all the modules covered by the Pen Plus will be included in this curriculum. And the way, a little bit of the context so that you can understand, this curriculum is coming to join other specialization in nursing that we already have. So it's embedded into the already existing Masters of Science in Nursing as a specialization, as a standalone specialization, because we have a Masters in Critical Care and Trauma, we have Perioperative, and so on. So this is like the 11th specialization that we are developing to address this issue, which is really a burden. To respond to the question how nurses will have been delivering care on their own at different health facilities. So this goes with the response from the previous presenter that the Pen Plus is a multidisciplinary approach. We are not working, nurses, they are not working in silos. They are working in collaboration with different team specialists, medical specialists. They are working with different people, even physiotherapists, as we are talking about the rehabilitation. So at district hospital, we do have, in Rwanda, we have NCD clinics run by nurses. But all those nurses, they are supported by the medical specialists. They are not working alone. But you know how many specialists do we have in a district hospital? You may, from your experience, you will tell me that how many specialists in our low and middle income countries, how many specialists do we have in our health facilities? They are quite few, they are still few. So to address this, we are specializing these nurses. And as the sustainable way, we are working with the Ministry of Health. They are endorsing the program, and it's included into the system, the already running program at the University of Rwanda, and it's endorsed by the Rwanda Nursing and Midwifery to address the issue of sustainability. So for the future plans, all the plans with regard to budget, with regard to human resource, this program will be also included. This to answer to the question of someone who asked about whether this program was fully funded by Pen Plus. We are appreciating the support, the financial support and technical support from the CIS. But the University of Rwanda was also there because it's already embedded into the already existing system which is already running, because there are academic faculty who are already hired by the university. They are already employed at the university. This is a support. So it's a joint collaboration by the University of Rwanda, CIS, and the Ministry of Health. That's in short what I can say. Thank you so much.
Thank you, Professor Olivier, and we really must move because we have to go to the two parallel sessions. And thank you for talking about all those partnerships. Just don't forget about the people, meaningful involvement of the people. I notice we have champions, civil society, Benda Kithaka from my country is reminding me you must mention about the people, not just ticking a box, but meaningfully involving them. Actually, the former WHO Director General, Margaret Chan, said you are either around the table or on the menu. We must involve these people that we are working with, not just as ticking a box, but meaningfully. We will break into two sessions. One is the UNICEF Childhood Onset NCDs, that is sharing an agenda between NCD and maternal and child health communities, and the importance of peer support, expert patient and patient navigators in chronic care for children and young people. That will be happening in the SILOS conference. Where is the SILOS conference? Somebody who knows which side so that we can save time? It's right here. So you're remaining behind here. And then we have one that is being hosted by the Global Coalition for Pediatrics and Congenital Hearts, that is calling governments to action on the childhood onset heart diseases. And this is building up on the case for a 2027 WHA resolution on the same, and it's going to be in the Mikumi Conference Hall. Mikumi Conference Hall is which side? When you get out, you turn right, okay? Turn right when you get out. So we will have that session for the next close to 30 minutes or so, or 45 minutes. Then we will have a health break, and then we will meet here. So the conveners of those two, I will be shuttling between the two to inform you when to collect the people back here. Allow them some tea before they come in. So we'll coordinate with you because our times are off. We started a little late, so we'll tell you when we'll be back here for the next session 3, which will be on policy to access. Thank you very much. This session is adjourned.
Good morning, everyone. So 2 minutes from now, I'll request everyone to be seated. So we'll be starting with the next session. Good morning, everyone. 2 minutes from now, we'll be starting with the next session. You can think about the energy of walking to the other room. It's a lot of energy. It's much better to sit down, yes. Good morning, Honorable. Good to see you. Could the IT people please display the banner here? As people are settling down, could they display the banner? Just an overview. The session will be talking about the integration of maternal, adolescent, and child health with NCD programs, national programs. So that will be the main agenda of the session. So experiences from advocates, experiences from national. Yes, yes. So 1-2 minutes to settle down, and then we'll be starting with the next session, please. So good morning, everyone. For those who are standing, I will be calling you up front to open for us. If you're standing, please, can you take a seat? I need only one person to be standing, and that is the person who will be giving us the opening statement. If you're standing, please, in the back. Sadly, I know some of your names. Dr. Colin. Dr. Colin. Yes, if you're standing, please, can you take your seat? Yes. Patrick. Patrick, if you're standing, please, can you take a seat? Yes, please. It is sad I know your names. Thirty more seconds for people to settle down. Please, can you settle down? So it is such a beautiful Wednesday morning to start our session today, and our session is going to be talking about UNICEF focus agenda of children. And when you talk about children, children brighten our day. I want to say and boldly say that one of the pinnacle of the ICPPA is the children who held their postcards here yesterday and were sharing different messages. And one of the main messages they were sharing is that we really need to fight and stop NCDs because it is very important to protect the children and the young people. So as we start our session today, my names are George Laura Msengi. I'm a medical doctor from Tanzania, the national liaison for NIMRI, which is the National Institute of Medical Research, to WHO and to the Ministry of Health for PEN+. And I will be your moderator for today. So to put forth a bit of a foundation into what we're going to be doing, we're going to be talking about childhood onset of NCDs as a shared agenda. And when you talk about shared agenda, there's a lot of verticalization in our countries. So to put this at a better perspective, I'd like to call forth our first speaker, who is going to be setting off the ground, Raul. So Raul Bermejo, am I saying that right, Raul? Yes, Raul Bermejo is from UNICEF, Global Health Practice. And Raul, as you're coming forth to the podium, I'd like for us to get a bit of a better understanding on why childhood onset NCDs for now must be treated as a shared maternal, child, and adolescent health agenda to the NCDs agenda rather than as a separate program. Raul, welcome to the podium. Please, our hands of applause.
I'm much smaller than George. Good morning, colleagues, distinguished guests, partners, clinicians, policymakers, youth advocates, and friends. On behalf of UNICEF, it's my extreme pleasure to welcome you to this session that's entitled Childhood Onset NCDs as a Shared Agenda, Strengthening Linkages Between Maternal, Newborn, Child, and Adolescent Health and NCD Programs through Primary Health Care. I'm Raul Bermejo. I lead our UNICEF's global work on childhood NCDs, and really a pleasure to be here again. The first time I attended ICPPA 2 years ago in the same hall, I made this observation at the time that we really need to make sure that at least for childhood onset severe NCDs, that it's not just an issue that the NCD community embraces, but it's also shared with the broader maternal, newborn, child, and adolescent health community. And hopefully we're taking steps towards that. So let me begin with an observation that many of the conditions we discuss at this conference do not begin in adulthood. They begin in childhood. A child born with sickle cell disease, a young girl diagnosed with type 1 diabetes, an adolescent living with rheumatic heart disease, a child surviving from cancer, these children are living with conditions that require not a single intervention. They need a lifetime of care and support. Yet our health systems are often not organized around their realities. Maternal, newborn, child, and adolescent health programs are designed to find children, vaccinate them, prevent diseases, and respond to acute illness. NCD programs, on the other hand, have traditionally focused on adults and on the prevention and management of chronic diseases later in life. The sad result of that situation is that children with severe chronic conditions, severe NCDs, frequently fall between the cracks. They may be diagnosed too late, referred too late, lost to follow up, or forced to navigate fragmented systems that were never designed around their needs. It is that fragmentation that this panel today will try to challenge and address. Because childhood onset NCDs should not be viewed as the responsibility of MNCAH programs or NCD programs alone. They should be a shared agenda. And primary health care, we see, provides that bridge. Primary health care is where children are first seen. It is where families seek advice. It is where prevention, diagnosis, treatment, follow-up, and community support can come together. It is where we have the greatest opportunity to connect child health services with initiatives such as PEN and PEN Plus and create integrated continuum of care. If we are serious about improving outcomes for children living with severe chronic conditions, we need systems that ensure that we find them early, refer them early, diagnose them early, retain them in care, and make sure that they are supported at home and in their communities. No single program can deliver all of those functions alone, and that's why we think it really requires a strong collaboration between MNCAH programs and NCD programs. One of the most important lessons emerging from countries is that integration is not only about services, it is about people. It is about empowering expert patients and caregivers. It is about listening to young people living with these conditions. It is about listening to young people living with these conditions. And I repeated that intentionally. And it's about designing systems that respond to their needs. And so and that's why I'm particularly pleased today that we will be joined by a youth advocate living with sickle cell disease, alongside with our practitioners and policymakers as part of this panel. The question before us is not whether integration makes sense. The question is how we operationalize it. How do we align policies, financing, service delivery reforms, workforce training, referral systems, and community support and community engagement to make sure that we deliver continuous person-centered care throughout the life course. The other day, I learned an important lesson from a UNICEF colleague from Zimbabwe. She told me, Raul, don't think too much. Just do it. So I hope when we have our discussions, we will have intense discussions. Let's not think too much. We should just do it, because ultimately our goal is not to simply connect programs. Our goal is to ensure that every child with a chronic condition has the opportunity to not only survive but also thrive. Thank you for joining us, and I look forward to the rich and practical discussions ahead. Thank you.
Raul, before you go back, before we put our hands of applause, you have told us on the essence.
Yes.
So I have a very simple question. So what is a risk at the end of this session if we don't have a conclusion that we're not going to integrate? So I have a question. What is the risk of children and adolescents when the maternal and child health program and the NCD services remain fragmented?
Well, the biggest risk is we do not reach our goal, right? We have been talking about in this conference, I think it starts with this very ambitious vision. And I think if these two communities come together, do not come together, the biggest risk is that we will fail.
Perfect. Thank you so much, Raul. Let's put our hands together for Raul. And Raul has set a very, very clear foundation on why are we having this session today. Now, Raul has said an advocate is coming here, but I will not use the word advocate only. In the morning when we were having a simple briefing, I said, I usually like to call her and the many more champions. So let us put our hands together as we call forth here up front our champion, our survivor, our fighter. Let's put our hands together for Arafa. To many who are practitioners here, you'll have so much more to learn from her than your day-to-day practices, because we learn a lot from the books. She learns from her daily experiences and has so much to share with us. Arafa, karibu.
Well, this suits me well, like Raul. Thank you so much. Good morning, distinguished guests, policymakers, healthcare professionals, partners, fellow advocates, and young people like myself. My name is Arafa Salam Said, a patient and a youth advocate, member of Voice for Pen Plus, founder of Sickle Cell Disease Patients Community of Tanzania. I was born with sickle cell disease, a childhood onset non-communicable disease that has shaped every stage of my life growing up. I experienced painful crises, frequent hospital visits, missed school days, and moments of uncertainty about what the future would hold. I watched my family navigate a healthcare system that was often fragmented, where continuity of care dependent not only on the availability of service, but also on our ability to find and connect them. Yet I stand before you today because of the care, support, and opportunities I received along the way. My journey has taught me that when children are diagnosed early, connected to quality care, and supported through their lives, they can survive, thrive, lead, and contribute meaningfully to the community. It is also why I chose to become an advocate today, to ensure that no child living with NCDs feels invisible, unheard, or left behind. Today, I stand before you not only as an advocate, but as someone who has witnessed firsthand how non-communicable diseases shape the lives of the children, adolescents, and families. Behind every statistic is a child trying to attend school despite the pain, a parent making difficult choices to access care, and a young person wondering whether their condition will define their future. As a person living with sickle cell disease, I understand that childhood onset NCDs are not simply medical conditions. They are lifelong journeys that affect education, mental health, social inclusions, economic opportunities, and overall quality of life. Yet, too often, these conditions are addressed through fragmented systems that fail to meet the long-term needs of children and adolescents. Many young people fall throughout the cracks between maternal, newborn, child, and adolescent health services and NCD programs, resulting in delayed diagnosis, interrupted treatment, and preventable complications. For children born with conditions like sickle cell disease, early diagnosis and comprehensive care can mean the difference between merely surviving and truly thriving. As a young person, we do not simply need healthcare services. We need healthcare system that sees us, hears us, and grows with us. We need primary healthcare platforms that integrate prevention, early diagnosis, treatment, psychosocial support, and long-term follow-up. We need systems designed around people rather than programs. Meaningful youth engagement is essential in this journey. Young people are not just being beneficiaries of health services, we're experts in our own experiences. When our voices are included in policy design, service delivery, research, and accountability mechanisms, health systems become more responsible, equitable, and effective. As we begin today's discussion, I encourage us to think beyond program silos and towards a shared vision where every child and adolescent living with NCDs receives continuous quality care through their life courses. Let us build stronger bridges between maternal, newborn, child, and adolescent health and NCD programs. Strengthen primary health care system. Ensure that no young people is left behind simply because the system was not designed to connect their needs. My presence here today is not only personal story, it is evidence of what is possible when children living with NCDs are given the chances to survive, grow, and reach their full potential. Together we have opportunity to transform lived experience into lasting solutions. Children living with NCD do not experience their lives in fragments, and our health system should not care for them in fragments either. Thank you so much.
Thank you very much, Arafa. Before you go back, again, Arafa, before you go back, I know you set the tone to be very diplomatic. Arafa, I've known her personally as a friend, as a champion again. Arafa is very energetic, and I want to ask one question to set a different tone right now. So when you talk about lived experiences and sickle cell disease, what has been your biggest challenge in navigating through the system as a young person? Karibu.
Asante sana. Wow. I think.
And let's go to our the way we talk. Yeah. Yes, this is much better. Yes, much better.
Okay, I think growing up with an NCD, the biggest challenge is the understanding of what you really go through. So as you doctors go through a lot with the books, don't really understand when I tell you today I'm in this much pain because of 1, 2, 3, and you just hear that you haven't taken a lot of fluids today. You have been working too much, but I'm a warrior for a reason. I can work, but also sickle cell can put me down when it feels like. Whether I drink a lot, I rest a lot, but I can have an 8-hour sleep and still wake up very fatigued, that I don't even feel like pulling out from the bed. So I think we should listen more to what the lived experience tell us, and not go back to our books and say, but my book said when you drink and rest a lot, it can help, and you're supposed to feel like this today. Or or judge me because my labs say my hemoglobin is 8.6. No, my body feels otherwise than what my labs can say. But thank you so much.
Thank you so much, Arafa. Let's put our hands together for Arafa as she goes back. Yes, you can go back. We're clapping for our champion. She is our champion. And not only Lucy, can you stand up? Lucy, yeah, just stand and wave. She's not alone. We have other champions here. And if we have anyone else living with NCDs here, we're clapping for you. And we can all stand up and put our hands together for them. Can we all stand up? Yes, we're having a standing ovation for all of them. We really appreciate you. We really honor you. And we are here together in this. Thank you. Can we all sit down? Dr. Edna, our pediatric endocrinologist. The message here is for us doctors here. So let us be more empathetic. And rather than reading what the books tell us, diseases don't read books. Thank you so much. I would like to take a minute to appreciate and honor katibu wetu mkuu yuko pale nyuma, Professor Nagu. I'm speaking in Swahili. Our permanent secretary, deputy permanent secretary is there together with us. She was not here yesterday, but she has given us the honor of attending our session. So could you just please stand and wave, Professor Nagu? Thank you so much. Yeah. So now we're going to go into our very quick run short of panel. And this panel is going to be talking about the aspect of integration together with primary health care. So for start, I would like to call forth Dr. Terence. Dr. Terence, can you please come in front? Dr. Terence is a Child and Health Program Manager together with the NCD Manager for Zimbabwe. Our hands together for Dr. Terence. Please. We'll be calling also Professor Edna Majaliwa. Yes, please come. Our pediatric endocrinologist, and should I say the secret? I shouldn't. She is a mother of beautiful 3 twins, or triplets, yes. Wonderful. And we'll be calling forth Dr. Judith from Uganda. Our hands together. She is our pediatric cardiologist who is the long-term care and referral systems director for Uganda. We also have Dr. Felix. Yes. Dr. Felix is our Assistant Director for Child Health in the Maternal and Child Health Directorate from the Ministry of Health. Karibu sana. So we're going to be having a few questions to them. That is how we're going to run the show. We have a few questions to them. And then we're going to have a question that is directed to the entire panel. And then after that, we're going to have a question that is directed to, a question that is directed to developmental partners, together with the government representatives that are here. And then we're going to have a final round from the panelists, and then we're going to have audience discussion. So this is supposed to happen within the next 30 minutes. So we'll try to be as fast as we can to run through this program, and then we're going to be having closing reflections. To go straight to the panel, I'd like to start with Dr. Terence. Dr. Terence, with your experience from Zimbabwe, what are the practical steps that countries can take to actually integrate better maternal and child health services together with NCD services within the primary health care platforms in the country? Karibu.
Okay, thank you so much, moderator. Good morning to you all, colleagues. Hopefully in the next few minutes, I'll go into details about implementation and not bore you with high-level steps that I think can be implemented. Firstly, I think we need to leverage on existing platforms that we do have. I'll give you an example. In Zimbabwe, I think we have IMNCI, which is Integrated Management of Neonatal and Child Health Illnesses, which I think over the years was really focusing mostly on acute conditions that were actually contributing to much mortality. But we did take a very bold stand, and then we did not only just improve the guidelines to have a component of NCDs, but we really have clear points of entry into the NCD program, which can actually assist in terms of screening these children. So this is one platform that I think can be used, just leveraging on the existing IMNCI for the younger children. Some of you might then ask, what about the older children? Because I think IMNCI is limited in terms of age. We have had robust programs in terms of adolescent sexual and reproductive health. And to some extent, we have had adolescent corners in many facilities. As an example, actually in Zimbabwe, we do have some facilities which were certified to have some robust adolescent corners. So one of the things is to leverage on that. We have actually found a way to bring the adolescents to our health facilities. Why don't just offer all the services and then give information about NCDs and also just screen for NCDs? So leveraging on adolescent corners is one of them, and I think we have done it in some of our facilities. The other issue is actually the HIV program, which came with some robust initiatives, and one of them was to try and keep adolescents in care and also improve their viral load control. And I think in some facilities in Zimbabwe, we've also seen that be helping in terms of integrating NCDs with other programs such as HIV as well, where we bring the adolescents to those facilities. So those are some of the issues in terms of leveraging on existing platforms. I think the other issue is really in terms of awareness. I think one of the issues has been low awareness, and what we have tried to do was to incorporate health education, actually starting from ANC, because I think I believe whatever a child becomes starts in ANC, and actually pregnancy can actually influence what becomes of a child. So giving information about where to get screening, what are some of the telltale signs or early signs that a mother or a parent should actually know before for them to go to facilities for early screening. So incorporating that NCD awareness, starting from ANC and actually to postnatal, using various levels. We have actually used our community cadres, which are the village health workers, and also at facility level to make sure that we spread this much awareness and everyone is also aware of non-communicable disease, particularly in children, and how the onset actually starts. The other issue that I would like to talk about is capacity development and training, particularly of those that are involved in programs that involve children. So we have nutrition programs, like also school health programs, where we have made a deliberate stand to try and make sure that those that participate in school health programs, they are very much aware of childhood NCDs And whenever they go to schools, we take that opportunity for us to screen children for non-communicable diseases. And I think lastly, so that I do not spend much time and allow much more time in terms of discussion, is really the actual implementation. So we were very deliberate in terms of setting up our Pen Plus teams. As you have already heard, these are multidisciplinary teams, but one of the nurses or some of the nurses that are part of the Pen Plus teams are actually from the Family and Child Health department, where we see most children, probably sometimes up to 12 years, it usually depends with facilities, to make sure that they are part of the team and they're actually one of the entry points in terms of screening. In terms of implementation again, we would see that sometimes we have some facilities which are doing a one-stop shop if resources are permitting and infrastructure is permitting. And then sometimes we also do have intra-facility referrals, where we cannot have a one-stop shop in the family and child health departments. I think let me end here for now, so that I think we'll give more time in terms of.
Yeah. So in three statements, before we put our hands together, in 3 statements, can you tell me the 3 key steps that you have just said that are practical? Just the 3. I got a few here I noted, but I want us. So how many know American Got Talent and British Got Talent? By your hands up. So now we're going to have ICPPA Got Solutions, and these are your judges. If they believe your solutions are impractical, they will tell us. So yeah, if whatever you are telling us here, Dr. Terence, we think does not work, we will tell you. So we'll make it interactive, and please, we can note them down. So the 3, please, can you mention them?
So firstly, it's about leveraging on existing platforms that we already have, where we are seeing all these children and adolescents. I've mentioned the MNCI, I've mentioned the adolescent youth corners, in some HIV programs focusing on adolescents, instead of making other platforms.
Don't re-elaborate them, just say the sentences in simple baby terms.
Yeah. And then the other issue was really to focus much on
awareness
and
cooperation.
Yes.
And the third was to make deliberate actions.
Yes.
Okay, thank you very much. Our hands up, pulse. So the next speaker, which is our very own Edna Majaliwa, will be giving us from a clinical perspective, especially as a pediatric endocrinologist on the ground here in Tanzania. So when you talk about continuity of care for children, what is the biggest gap that you actually identify and notice? And how can primary healthcare systems address the issue of continuity of care, especially for children and young people with chronic conditions? Dr. Edna, please.
Thank you for the question. My name is Edna Majeli, as mentioned, and I've been working with children with chronic endocrine issues, diabetes specifically, and now I'm in Pen Plus. So what are the challenges? I'll start from Arafa. Arafa has told us when they tell us we should listen and not imagine or judging that, because the book says you have pain, you need water, and you're not listening to them. So my first challenge will be awareness among the healthcare providers. Sometimes they're not sure what to do in these chronic conditions. Our system for a long time has been on acute condition. We treat and you go, but you're coming today and you're coming tomorrow. The day after tomorrow, we're seeing you. So at a point, you don't know what to do, and they're not well, they're complaining. So sometimes we are unaware. We know the condition, but we are unaware what is happening. Or sometimes the healthcare providers might not know what it is. So we end up with delayed diagnosis, misdiagnosis. And when they come to us, they have complication already, and they have to go to the higher levels than the primary one. But and that is one. But then in our primary levels, the availability and affordability of monitoring tools, diagnostic tools might be on and off. Then they might be not consistent, and because they're not being used that much. Nobody at one point was thinking a child might have diabetes, but now we're thinking that a child can have diabetes and any other disease. Essential medicine like insulin, it was not lower down in the primary level. Now it is. But so someone in the lower level, it's difficult to prescribe insulin, for example, or hydroxyurea. But now you can see at least that is improving. So, and the continuity of care from pediatric to adults is, we don't have a structured system. So it's usually difficult. It's like we're transferring patients from here to the next level, and we're not really, what should I call it? We are not transitioning them. So at the end, we lose them. So we have a lot of loss to follow up, because they go where they don't know, and sometimes the physicians are to say, might not take care of an adolescent, I'll call, or a young adult, like how they're being taken care of with a pediatrician. And that is difficult. So they will not go back to the hospital. And we've had, in Tanzania, we've had these programs, like we had Life for a Child, CDC, which has brought in patients, and there are many patients. And at that time, possibly we were doing a survival. And I know there are sickle cell programs, and we're doing survival. So children were surviving. Now where we're going, we want quality of care. And when you put Pen Plus in, so what it has done now, the training and mentoring is helping to, first, it's retain those people in that area, and then you're improving the quality of care, and you're improving, like specifically for diabetes, you'll be improving the diabetes control, and they have good glycemic control. But even in those patients with sickle cell disease, the frequency of anemia or transfusion will reduce, and that will be a good thing for a clinician, because seeing someone every day with complication, decay every day, it is heartbreaking. And so if you use the Pen Plus model, that means we are going to reduce the number of patients coming in the tertiary zonal hospital, and they go to the primary level where they can be taken care of. And very few patients will come to the high level where they already have complication, and then they'll have a quality of care. You can't see, say, 50 patients in a clinic and say you're providing a quality care. And those the difficulties we are having. But now with the integration, so we know with healthcare, we're not many, and we need this one person to see someone with HIV, with diabetes, with sickle cell, with rheumatic heart disease. They see everything. So when you train them and train in different things, but this is one person, and they'll be able to manage everyone. So we will have resources that will fit us all. It won't be much, but at least to fit us all. It will fit a non-communicable disease person, and it will fit someone with an acute illness. I'll stop there for now. Thank you.
Thank you, Dr. Edna. So we have not given you the buzzer button here. We have not given you the buzzer button yet. So we asked you regarding the gaps. And you've told us most of the things you've told us are actually about policies. Availability, affordability, transition issues for children. You've talked about the issue of utilizing programs as a way for primary health care to integrate, like the Pen Plus and other training and mentorship programs and incorporation of resources. Thank you very much. And our judges will give you their feedback in the question and answer session. So we're coming to the next person, who is Dr. Judith Namuyonga. Did I say that right?
Yes, you did.
Perfectly well. So Dr. Judith from Uganda, you're going to tell us a bit regarding how can countries actually strengthen referral systems and long-term follow-up for children and adolescents living with chronic conditions such as rheumatic heart disease. Karibu.
Asante. Habari ya asubuhi. Thank you for having me here. I will start with a story. 5-year-old, I think she was a bit older, child to a member of parliament in Uganda several years ago, walks into the Uganda Heart Institute with her daughter that had been in a boarding primary school. Comes in with difficulty in breathing and chest pain. And she says, my child was in boarding school, complained of joint pains, and the school nurse was giving diclofenac gel, applying to the swollen joints. And this happened over and over. When we saw the child, they had advanced rheumatic heart disease. This is a child to a member of parliament. Number two, just last week I saw a child, actually two children in one family that had sickle cell anemia. And the mother had come once to the sickle cell unit in the National Referral Hospital, but could not bear with the big lines and the queues and the stigma that she got every day. And so she chose to go to a private hospital. She doesn't believe in hydroxyurea. This is an affluent mother. She doesn't believe in blood transfusions. Her son had acute chest syndrome and HB was 7.9 and they needed blood. So I get a call and I'm told this family does not believe in hydroxyurea. Remember, I'm a pediatric cardiologist, but I'm also a pediatrician. And the mother said no, even when we advised, and oxygen saturation was 79 on room air. She said, I'll go back home with my child. Declined admission. Now, how do we sustain and how do we build better referral systems? We have a high burden of disease, and so we must be smart as we work in the PEN Plus system. 23%, okay, in Uganda, about 20,000 children are born with sickle cell anemia every year, and 16,000 have congenital heart disease. 8,000 of these with congenital heart disease require some form of intervention, interventional without open heart surgery, and others require open heart surgery. Rheumatic heart disease, when we looked at our study at the Uganda Heart Institute, was among the 30%. The 76% were congenital heart diseases. As we've gone to our PEN Plus sites in Uganda, we found a lot of congenital heart disease. And if we found RHD, it's mainly the advanced disease that requires chronic care and some form of intervention, which is either surgery or valvuloplasty if they are adults. So the most important thing is early detection. Detecting disease prenatally. You know, you can prevent sickle cell anemia by talking to the public, passing around the news, getting them in the churches as they are going to marry, ask them, routinely the pastors and sheikhs and reverends ask for, have you done an HIV test? So we need to have this tailored. Have you done a sickle cell test? Hepatitis B, C, you know? This should be tailored. Now, in our referral system, we need to detect them early and match them. So prenatally, as this mother is pregnant, look out for the high-risk mothers. We screen for sickle cell trait in the mother and then catch this baby at birth and do newborn screening. If the mother in the family history has history of congenital heart disease, there's a 10% chance that another child may have, especially if it is complex. So that history is picked up and you do a usual obstetric ultrasound scan and look at the apical four-chamber. So in Uganda, we didn't have prenatal screening for congenital heart disease. We started this program 2029. I'd trained somewhere else on advanced echo and done fetal cardiology in that small training. So we had to start that. So scan these mothers, but it's not yet on a big scale. So scan them, identify who has congenital heart disease, pick them up in the newborn clinic, and advise those with complex heart disease to deliver at the tertiary centers where you can manage them well. 2, in the referral system, once you have identified, you know, you can't refer what you don't know. In medical school, they used to tell us the eye sees what it knows. So you won't know that this is advanced disease unless we have trained people well. So I'm happy with the Chigali team, the Rwanda team that have started a training program for the nurses, because the nurses are our foot soldiers everywhere in the Pen Plus program. In Uganda, we have many nurses, and you know, they listen. Doctors are too busy to listen to patients. That's why they'll quickly say, it doesn't pain. But the one who has the pain knows that it pains. But the nurses have this other mother figure in them. They will slow down and listen. So we could empower that. So early detection, pick them in the antenatal clinics, pick them in the postnatal clinics, screen for both high-risk pregnancies, type 1 diabetes. It's autoimmune, but if you find it in one, then there's an 85% likelihood that it will be in that other family. So the pathways will be through our Pen Plus clinics, and this is what we do. And Pen Plus has really helped us so much that this is a coordinated referral. In a heavily populated country, anyone walks into the specialist's clinic. Unplanned, you know, you walk into a daily clinic and you don't know who is coming. Other countries don't work like that. So Pen Plus, we organize our referrals. We have a list of who is coming to the center. Thank you. Who is coming to the center and when are they coming and who is bringing them. So that is better than when a patient walks in and you don't know them. Palliative care services are key in the community, at the hospital, at the low health centers, where Pen Plus is running. These palliative care teams, not all diseases are curable. Well, we are treating sickle cell, we are managing the pain, we are giving hydroxyurea, we are managing heart failure, but some things, remember, all these are chronic. So we need working palliative care systems. And in Uganda, regional referrals have centers, but where we are implementing Pen Plus, we do not have.
So when you talk about working systems, I'd like to jump forward to Dr. Bundala right now.
Yes.
Thank you so much, Dr. Judith.
Yeah.
Let's put our hands together. So Dr. Bundala right now, as we're talking about working systems, I will not go by the book and ask you the question that was sent to you, but let's talk about practical aspects. I have been supporting the NCD movement for the ministry for the past 7-8 years. And you are the focal for child health programs in the ministry. And I think we have not met before, have we? You don't remember, we have not met. It shows how much the support structures might not be incorporated. So my question is to you, that this is a clear example of how these systems can work in silos. My question is that what can be practical in terms of maternal and child health integration? It's similar to what you were asked before. And what are the NCD services that can be integrated at a primary healthcare platform? Karibu, Dr. Bundala, very briefly.
Thank you so much. I think delegates, I think very much honored to have this opportunity to talk a little bit the relationship within the reproductive maternal, but also the issue concerning NCDs, like NCDs, reproductive maternal. First of all, I better address that when we're talking about reproductive maternal, newborn, and child health, basically we're talking with a very big population, and it is a target, but also it is a platform to see how can be used to portray this information for NCDs. Because talking of reproductive age, some might know that you are talking almost half of the population, estimated in your 2022 census, like 30 million people lying within that category, but also talking with newborn, child, and the adolescent health. Again, this is almost above 40 million people, over 60% of the population. So it is a very big population we are talking about. And we all know that we basically interact with this kind of the group in different ways. That when I talk about the maternal, that every year close to 2.5 million women are getting pregnant, and over 90% of them, they are making at least one visit to our facilities. And over 81% they are delivering in our health facilities. But even those delivering out of health facilities, they will still come for the services at the home during the postnatal visit. So the question is, how much are we prepared to make sure that we have the appropriate information for them, but also the good services for them in terms of our infrastructures, commodities, our healthcare workers, the competencies on what should be done, but also the way we should be capturing the data for different services we are providing. So, as part of the response, I try and talk briefly what Tanzania is doing, like part of NCD within reproductive maternal. And I'm sure, surely I will talk the few I can remember, but not only that we are doing. Number one, starting in pre-pregnancy as part of the continuum of care, before we provide the family planning services, for example, that a particular client needed to be assessed or screened on issues like blood pressure, diabetes, and it is strictly prohibited to be provided if some of deferrable conditions are available. But also, we do have the program for the cancer screening, including cervical cancer screening, breast cancer screening, as part of issues done in pregnancy. But during pregnancy also, you know, when these mothers come for antenatal visit, also they are screened in number of conditions, including the NCD related challenges. And as I said, at least 98% of those who get pregnancies, they are able to make at least one visit. So post-delivery, also we think about the newborn care. Also, we basically included issue of the newborn screening in our infrastructures as we embark into building of the neonatal care units. Also, we have considered some rooms for the newborn screening, and we will be screening issues like retinopathy of prematurity, congenitals, including congenital heart diseases, issue of the sickle cell, and the like. So we also consider to start early, as it will have been said by law, that we need to make sure that we are not late to prevent the future severe illnesses. The childhood also, we have issues we are doing there. You remember, those who remember 30 years ago, those who are sitting in tables like this, in most cases they concentrated with the common killers by then, 90% being of under 5 who were being who died due to the common illnesses like diarrhea, pneumonia, and malaria. But currently now we're embarking with other conditions, and now we have even incorporated the sickle cell screening within our child health booklets. That one, it is there, but also issue of nutrition status assessment, that also we have incorporated within our documents. To the adolescent also, you know, as we focus issue of teenage pregnancy, HIV prevention, nutrition, and mental health. Also, when we are conducting like the Bonanza, different campaigns, we also make sure that we have we are screening for different conditions, including the NCDs and NCD things. But also we do have some of the campaign, including the famous known as Dr. Samia mentorship programs, where we send the specialists in a set. We have physicians, we have surgeons, we have pediatricians, OBGYNs. All this one, they do the screening, but also provide the services for the different clients that will be seem to have the problem. So to conclude, is that as we are talking, as we want to make sure that we improve this part, integration and the linkage needed to be the center of the solutions. But basically, as we are talking, as the primary health facilities where our providers are there, you might find that there's not much problem in terms of integration, because you find it is a nurse or a clinician doing the same thing. The problem sometimes starts to ourselves, the leaders, the donors. When we go there and they say, no, this intervention is only for NCD. This one is only for so and so. So discussing the integration to this level, we might be basically finding the solution to the problem that we have created ourselves. Thank you.
Thank you very much, Dr. Felix. A hand of applause for him. So when I was taking this bottle of water, some of you might have think I'm thirsty. I'm not thirsty. I'm going to put it right here. And this is our buzzer beat for solutions. If you feel like whatever solution is coming up from here is practical, implementable, you stand and you pick up the water. And that is our buzzer beat. Until then, it means we have a bit like 15 more minutes until the next session, and we'll try to finish this. So as we're waiting for that pinnacle solution, I'm putting the water here. Can we have our UNICEF representative who's going to tell us a bit in 2 minutes on how can actually governments and other developmental partners avoid program silos and support truly integration of programs? Dr. Diwan, please. In 2 minutes, Dr. Diwan.
So thank you, George. It's really a great privilege for me to hear in Africa, coming from Bangladesh, and to join this important conference. Thank you very much. So I would like to just bring the experience of how we started Pen Plus program, pediatric NCD in Bangladesh. Definitely, government should play the stewardship role in starting any initiative in a country. So UNICEF as a partner, and also working together with WHO, we try to first government in the stewardship lead to bring together, including professional bodies, academia, and the different programs, existing programs that government have, like IMCA program, like nutrition program, child health program, and adolescent program. So these are the key program, and for delivering all those program, I believe primary healthcare is the key platform to deliver those programs. So for designing this Pen Plus program, we try to bring together, government try to bring together all those partners, and that helps in designing program, in situation analysis, in identifying key areas that continue to address, prioritize, and then developing clinical guidelines and training package and conducting training. So all those help in the government leadership in developing the program. And UNICEF, as in, we support government strengthening maternal health program, newborn, child health, adolescent health, So we try to strengthening all those program and including community support system, social and behavioral change communication, and mostly initial targeting districts, selecting districts through our equity data and program. We support it. So I believe in different country level, that's the way the partnership can help. And definitely, WHO has a critical role in supporting countries with technical norms, with service package, clinical guidelines, and policy alignment. So these are the key areas. And I believe that our partnership should not be silos, and it should not be like targeting different partners, different training program, different monitoring framework. So all should be in a unified package. So that's what I can say. Thank you very shortly. But just to say, I was here in 2003 to look at the IMCA program as a part of WHO multi-country evaluation of IMCA program. So that's when I realized Tanzania has a very good primary healthcare platform. But now, after 23 years, I'm here again to look at the pediatric NCD. Thank you very much.
So in short, Dr. Diwan is telling us that we need to start from the planning of these programs. That's where it all starts. If we plan for integration, there's a possibility we might get integration in the end. So thank you very much, Dr. Diwan, for that. As we are moving towards one of the very important areas right now, I will not go towards a rapid question to all the panelists, but now I will open questions to the audience. And as we are thinking right now, dear audience, one of the areas that came to me, that seems to me is common in all of this, from the issue of planning programs to the issue of implementing programs is the aspect of sensitization. And I want to give a good negative example that can be taken positive. How many know about Ebola? If you don't know about Ebola, I'll call you here. How many so? So when you're sleeping at night, sometimes in Tanzania, you'll get a message at 3 a.m. You're saying, who is having a puncture somewhere? Which one of my friends has an emergency? And you open your phone, you open your phone and you find a message about beware of Ebola, you know? And you're talking in the street from a child who is literally 7, 8 years old. They tell you about Ebola. A week ago, I was traveling on the airline and there was a lady who was seated just a seat behind me. And there was a big commotion in the plane. Because after receiving her cup of coffee or tea or whatever, she was trying to give back the cup that was used to the air hostess, the attendant. And the hostess was like, no, I cannot touch that. Please throw it in the bag. You might have Ebola. And this lady reiterated, and she was like, do I look like Ebola? She actually didn't. She was well dressed. But the issue right here is Ebolalization. Can I use that term? Ebolalization. Ebola has come in recently, but has been sensitized everywhere. You know, we were in the organizing committee and we were trying to plan how should the conference be. And they were like, we need thermal scanners. There is Ebola. You might not know, but there's a thermal scanner and there's someone who is seated right there, screening you unaware. That's how NCD should be. That is exactly how NCDs should be. So if we're talking about one important term that I think we should carry from here in our today's meeting is NCD Ebolalization. Ebolalization. How many know Professor Julie Makani? She's right there seated. When you talk about Professor Julie Makani, what do you think about? I'm not hearing. What do you think about? So that's how it should be with NCDs. From the child, they should be sensitized. Just when you see Dr. Julie, you're not seeing sickle cell. That is not me, Professor. They are the ones who are saying when they see you, they see sickle cell. But it should be the same with NCDs. It should be so much sensitized such that when Dr. Felix sits and plans for his child health programs, he thinks about NCDs. When our endocrinologist sits and does her clinical practice, NCDs are at the forefront. So I'd like to open the floor for questions in the next 3 to 5 minutes maximum as people are coming in. And as they're coming in, everybody should know what is our new terminology, NCD